So hello friends, am I audible? Please let me know if I am audible, visible, everything is clear at your side so that we can proceed. Guys, please show me a thumbs up if I am audible and visible to you. Is everything good to go? Shall we begin? Hi Dr. Ahmed, good. So good afternoon everyone, welcome to the session and here I am Dr. Shivani Jain, your ophthalmology mentor at DocTutorials. So welcome everybody from all of us at DocTutorials. So friends, I am Dr. Shivani Jain, your NEET PG mentor at DocTutorials, and that's the book which I have written. So a brief introduction about myself, and you can find and follow me at two platforms, that is the Instagram and Telegram. I can share the link later on. And friends, today we are here to discuss the very important part. Like, we have given you a Elite series and this is in continuation of that. We will be talking about ophthalmology. We have given you 2 tests previously, and today we have a session where we will be discussing 60 most important questions here. So friends, I would say these are not 60 most important questions, rather these are the 60 most important topics which may be there in your upcoming exam. So we will be preparing those 60 topics nicely so that you become more confident in your exam. So I'm sure that you are preparing well, you are doing best, and you will be cracking your exams. You will get very good score in your upcoming exam. So how are things there at your end, guys? Yes, how was the test? Did you like the test? Was it tough, easy, super easy? So friends, it is an MCQ. Your test was easy, tough, okayish, or super easy? Yes. How was the test? You've given the test now. Well, how was the test, guys? None of you have given the test? So considering that test was not too tough, we will be having a discussion of all the questions that were there. So we are starting with the test number 1. The question number 1 here is that we have a 40-year-old patient who presented to you with redness and photophobia since 2 days. There's also a complaint of the same-sided headache. The vision was supposed to be 6 by 6. The vision is normal in both the eyes, but when you check the anterior segment, there is a flare and keratic precipitates. Now you also check the IOP, and IOP was definitely a little high, right? The IOP is around 26 millimeters of mercury. So friends, just by looking at this, can you get a provisional diagnosis? What is the diagnosis here? What is the problem? Just give me a second, guys. I'm not able to write down on my this now. What has happened? Give me a second, friends. I'm just fixing it. I'm not able to write down anything here. I'm not able to write down anything here. I don't know what happened. Not able to do anything here. कैसे करूं? So friends, now can you see me? Sorry for that technical glitch, guys. There was a problem. I couldn't write down on the screen. That's why there was a lag of time, guys. So I'm extremely sorry for that. Now let's come back to our question number 1. I was asking you, reading that question, can you make out what is the provisional diagnosis here? So we are discussing a case of anterior uveitis, isn't it? We are talking about anterior uveitis. Why? Because we have a young patient who has redness, photophobia. There is a same-sided headache. Why? Because the IOP is high on that side. So this type of rise of IOP is because of an inflammation in the eye, right? The vision may not be less in initial in initial period of uveitis. It may take some time for the vision to go down. Okay, so here we can definitely make out the patient has anterior uveitis. Looking at the anterior segment, there is a lot of flare and keratic precipitates as well. Now friends, so when you have a case of anterior uveitis, first of all, my question to you is, what is the drug of choice? So the drug of choice here should be a topical steroid. Okay, so what is the drug of choice? Drug of choice for case of anterior uveitis should be the topical steroids, right? Now, apart from topical steroids to the patient, we would also like to give cycloplegic mydriatic agents, right? So the role of cycloplegic mydriatic is that they will decrease the pain. First of all, they will dilate the pupil so that the sinae K which are formed will be broken down. The sinae K would be prevented from further forming, and these should be the drugs to be given for uveitis. Now, what about the high IOP here? So friends, here when the patient also comes to you with a high IOP, we would like to give an anti-glaucoma drug. But here please remember, prostaglandin analogs would never be given. Why? So latanoprost like drugs which are drug of choice for control of glaucoma here will be contraindicated because the property of PG analogs is inflammation. One of the side effects of PG analog is inflammation, and already we are dealing with inflammation, so we would never like to give a PG analog to reduce the IOP. Okay, understood friends? Now my next question, any other anti-glaucoma drug which again I would never like to give the patient? So I would also not like to give pilocarpine. Yes or no? So please remember, 2 PEs we would never give in anterior uveitis to control the IOP. First PG analogs, the second one is pilocarpine. So both of them would never be given. Now my next question, so what to give? We want to control the IOP, so which drug should be given? So the best drug to control the IOP in a case of anterior uveitis should be iotim. Iotim is nothing but timolol. Okay friends, so please remember, again I am repeating, to control the IOP in a case of uveitis or any other inflammation in eye, never give PG analogs, never also give pilocarpine, because both of them have a property of inflammation, right? Which drug to be given then? Timolol, iotim should be given. Okay bache, so I hope you've understood the question number 1. We were discussing a case of anterior uveitis. Now next guys, I would say retinoblastoma is one of the important topics for your PG entrance exam. So any exam you can get a question on retinoblastoma. So first of all, let's tackle this question. How does retinoblastoma spreads? So friends, as you know, it is a malignant tumor. It can spread by hematogenous route, by lymphatic route, and it can also spread directly through the optic nerve to brain. So I would say, what is the most common method of spread? The most common method of spread is the direct spread through the optic nerve. So guys, where will it go? It will go towards the brain, isn't it? So direct spread, the perineural spread through the optic nerve to the brain, this is the most common type of spread. Okay, please remember this has been there in your last exam also. So retinoblastoma, one of the frequently asked topic in your PG exam. So I'll quickly enumerate some important points here. So friends, this is the primary most common intraocular malignant tumor of retina, which starts early in the age, like about 1.5 years. This is the most common age of presentation. The most common type of presentation is leukocoria. So the patient presents with leukocoria or an abnormal white pupillary reflex. The most common method of spread is the direct spread through the optic nerve, right? Now, apart from leukocoria, the child can also present with esotropia. There can be endophthalmitis, proptosis. There can be a complicated cataract, and you can have various type of presentations for retinoblastoma. Now, the diagnosis is mainly by ultrasound B scan, and to confirm, you can see the calcification within the retinal mass, right? You can also do an MRI to know about the optic nerve spread. But if they ask you what is the most important one for diagnosis, say ultrasound B scan, right? MRI would be best to know whether the optic nerve is spread or not. Okay, how to treat? So nowadays the most important treatment is the primary chemotherapy, where we have a VEC regime. Guys, what is VEC? Vincristine, etoposide and carboplatin. Okay, so please remember, retinoblastoma, most important tumor for eye. Please remember this much, right? Chalo, now let's talk about the third question, friends. So we have an old patient who is also supposed to be hypertensive. This is a 64-year-old hypertensive patient who came with a sudden loss of vision. Now when you examine, hand movements were only present, so the vision is almost gone, and there is a relative afferent pupillary defect. Now what is the diagnosis? Now friends, when you have this picture with you, and you have typically a patient who has hypertensive who comes to you with a sudden loss of vision, what comes to your mind? What is the diagnosis here? So very good, Dr. Abhilash, this is the central retinal artery occlusion. Very good. Now friends, let us discuss this topic also, because this is one of the most commonly asked topic in your exams. So central retinal artery occlusion occurs first of all in old people who are supposed to be hypertensive, diabetics, atherosclerosis, hypercholesterolemia, hyperlipidemia. These are all the risk factors. Now what exactly happens? Yes, Dr. Abhilash, this is typically a cherry red spot. Yes. Now what exactly happens? So the embolus can come through your heart and lodge into the lumen of the central retinal artery just behind the lamina cribrosa, just behind its entry to the eye. Now what do you have here? This is a very important picture question. Here you have the Hollenhorst plaque, which is nothing but a cholesterol filled embolus. Okay, this is nothing but a cholesterol filled embolus. Okay, so this can lodge into the lumen of the central retinal artery. Now apart from Hollenhorst plaque, guys, you can also have a calcific plaque. You can also have a fibrin platelet plaque, right? So these three types of plaque are there. Now how does the patient presents? Typically the presentation of patient is nothing but the sudden loss of vision. Now this loss of vision is a painless loss of vision, and this is very profound. I am telling you, this is a very profound loss of vision. This is not exactly like CRVO. CRVO patient presents with a decrease in vision, but here CRAO is sudden complete loss of vision. Okay, please remember, this is a distinguishing feature. Now what will I see in my patient? I'll see the retina becomes typically white. Retina is white. Why? Because retina loses its transparency as there is ischemia mainly of the ganglion cell layer. Please remember, the ganglion cell layer is the most important layer. So this becomes ischemic, then retina loses its transparency. So I will see the retina has become white. This is typically a white retina. What all? When I see the retina has become white, I typically also see a red spot at fovea. As he said, typically this is a cherry red spot. Okay, this is nothing but the cherry red spot. Apart from that, I can also see segmental blood flow, which is also called as a cattle track sign. Okay, so I see three things: a white retina, a cherry red spot, and a cattle track sign. Okay, now can anybody tell me how are you going to treat it? How are we treating it? So friends, first of all, the prognosis is very poor. Prognosis is very poor because the salvageable window is only 1.5 hours. It's only 90 minutes. But definitely when the patient comes to us, we give a vigorous ocular massage. The reason behind this is that once we give a ocular massage, the embolus may dislodge. Okay, so I'm enumerating how to treat. First, ocular massage. Then you can vasodilate the vessel. If you do a vasodilatation of the vessel, the embolus will again be dislodged. Okay, vasodilatation can be done by giving CCBs, by inhalation of the carbogen mixture. You can also reduce the intraocular pressure, and as a final resort, what can you do? As a final resort, you can also give a thrombolytic agent, that is your intraarterial streptokinase. Okay friends, so this is how we go about, this is how we treat. Okay, so CRAO, please remember, it is a very, very important topic. Okay, now the next one. So we have a small child. We are talking now about a 7-year-old child who has come to you with decrease in vision. On examination, the vision is not improving with pinhole. Okay, the vision is not improving with pinhole. Now, the fundus is normal, the pupil is also normal too. What can be the most probable diagnosis? Okay, before that, I'll take up his question. Yes, Bachi, Dr. Abhilash, we can also give hyperbaric oxygen, that is a mixture of carbon dioxide and oxygen. So that will vasodilate the central retinal artery. Absolutely correct. Yes. Okay. Now, so I am now talking about this question. So here we have a child who has a decrease in vision. His vision is not improving with pinhole. The retina is normal, the pupil is normal. So what do you think is the most important diagnosis? What is the diagnosis here? So friends, I would say the diagnosis here is nothing but amblyopia, right? So you are not able to find any organic cause. We don't know what is the reason of decrease in vision, and it's not improving further with pinhole. Now, what is the role of pinhole? First, let us understand this, as this is also an important picture question. Okay, so see this picture beta, this is your pinhole. It has a central aperture of 1 millimeter. So if anybody comes to us with a decrease in vision, we first of all ask the patient to read through the pinhole. Now if the patient improves, now that means the vision improves with pinhole, it suggests that the patient has a refractive error, isn't it? Refractive error generally up to 4 diopters. Okay, if the vision improves, it means the refractive error is there up to 4 diopters, right? Now, but what if the vision does not improve? If vision does not improve, it means there is something else as a reason apart from your refractive error. Okay friends, please remember this is important, right? Now, let's come back to the question. So here, why the diagnosis is amblyopia, friends? So amblyopia is what? We also call amblyopia to be lazy eye. Okay, so here this is a cause of decrease in vision where you are not able to find any cause in the eye. There may be some problem in the binocular interaction. There may be some problem in the formed vision. So there may be a stimulus deprivation. We don't know what is the cause. We are just having some kind of postulates, some kind of theories where there can be a decrease in vision. Right, so amblyopia is a very, very important topic. We can have different causes, like there can be a stimulus deprivation, there can be an anisometric amblyopia, there can be a strabismic amblyopia, and the next one, you may have an organic cause for amblyopia. Now, how do you treat amblyopia, anyone? How are we going to treat amblyopia? So, first, if you are able to find out the cause, treat the cause. Okay, if you have a high refractive error, treat the refractive error. If you have strabismus, treat the strabismus. If you have a congenital cataract, treat the cataract. And then later on, do a patching of the normal eye. Why? When we patch the normal eye, we give the chance to the lazy eye to see more. Isn't it? Yes. Patching is the one and penalization is the one, right? Age is diagnosis little bit. Age is difficult. No, beta, Abhilash, you can have amblyopia at 7 years of age also. You know, the child has come to us late. Isn't it? The child has come to us late, right? Yeah. Dr. Banwari, though, no, it is not D. No, it's not D. Okay? Answer is amblyopia here. Amblyopia. Okay? So, now let's talk something about glaucoma. So, fibers last to be involved in glaucoma. What are these? Anyone? What are these? So the fibers last to be involved in glaucoma should be the papillomacular bundle. Papillomacular bundle. Okay, let us talk about first of all what are the fibers, what are the orientation. So guys, this can be an expected question. They have given you questions oriented to this diagram many times in your exam, but I want you to understand this topic well, okay, because again I'm suspecting this question can be there in your exams, right? Now friends, what I'm showing you in this picture, this is the arrangement of the retinal fibers. How they are arranged, let us see. So friends, this is your optic disc, isn't it? That's your optic disc. And what are we showing you here? Please see the nasal fibers are coming like this, and they are converging on the nasal upper part and the nasal lower part of the disc. So we call them the superior radiating fibers. Please remember the name, superior radiating fibers, right? Now what about the temporal fibers? So temporal fibers are coming like this. Can you see? They are coming like this, and they are now inserting on the upper and the lower part of the disc like this. Now what about papillomacular bundle? So please see, papillomacular bundle means what? Papilla means the disc, macula means the macula. So those fibers, those bundles which are coming from the macula are now coming on the temporal part of the disc, okay? So please remember, the arcuate fibers are the first one to get affected in glaucoma. They are the first one to be affected by a high intraocular pressure, okay? Now what is the clinical inference? So guys, do you remember that in glaucoma the first important visual field effect was what? It was a wing-shaped paracentral scotoma. And where that wing-shaped paracentral scotoma is forming, it is actually forming at this particular site, isn't it? If you go back to your visual field charting, you will see that here we have a blind spot, and the first important scotoma would be a paracentral wing-shaped scotoma. So this is forming where? This is exactly forming at the same site where we have arcuate fibers. Why? Because these are the first one to get damaged. Understood the clinical interpretation here? Yes. Now you remember that the central vision is preserved till the end in glaucoma. So central vision is preserved. Why? Because the papillomacular bundle is much resistant to a high IOP. Okay friends, please remember a very important topic. Yes, Jerum's area is this area. So the superior arcuate fibers, what you see in the visual field, this area is the Jerum's area. Absolutely, Dr. Abhilash, this is absolutely right. So this one is your Jerum's area, right? So mainly in the Jerum's area you get the glaucomatous field effects. Why? Because these areas are formed by the arcuate fibers, okay? So again, arcuate fibers are the first one to get affected in high IOP. Papillomacular bundle is resistant, much resistant to high IOP. But yes, definitely if you have a very high IOP, the central vision may also go, okay? Good one. So this is a very important topic. The arrangement of fibers are equally important, okay? Now something more from glaucoma friends. The progression of ocular hypertension to primary open angle glaucoma is determined by all except. So thick cornea, family history, advancing age, or increased cup to disc ratio. So if you remember the ocular hypertension treatment trial, what was ocular hypertension treatment trial, beta? What is ocular hypertension treatment trial? So it was a large clinical trial which was done on patients of ocular hypertension, and they studied that how much percentage of patients will be finally going towards development of primary open angle glaucoma. And this study also told you what are the risk factors, why somebody who has an ocular hypertension will later on be converted into primary open angle glaucoma. And these were the risk factors. So the first one, the most important one, is advancing age, okay? Next, you may have a positive family history because you have some kind of genetic predisposition for primary open angle glaucoma, okay friends? Myocilin gene is very important, okay? Please remember the name of the gene, myocilin gene, right? Now apart from that, what are the other risk factors, guys? Advancing age, a family history. I hope you remember. The other ones are myopia, the other ones are, anyone, what are the other ones? So other ones are male sex, yes, blacks, it is more often, more commonly seen in blacks, and somebody who has a high cup to disc ratio, and a very, very, very important question here is a thin cornea. So somebody who has actually a thin cornea is more likely to develop a primary open angle glaucoma later on rather than a thicker cornea. Okay, so please remember, a thinner cornea is a risk factor, not a thick cornea. Okay, so guys, very, very good. Most of you are correct. Dr. Vikas, no, it is not C. You see mainly primary open angle glaucoma in elderly males. Okay, so again, what are the risk factors? Male sex, advancing age, myopia, blacks, thinner cornea, and a increased cup to disc ratio. Now, I haven't told you what is the most important one. So the most important one, of course, is a high intraocular pressure. Why I'm telling you this late? Because this is the only modifiable risk factor. Okay, when you see all of them, what is the only modifiable risk factor? Only modifiable risk factor is a high IOP. Rest of them are not modifiable. Understood? So please remember, a very, very important topic. Last year, guys, you had a question from genetics. So you may have some more questions from studies related to glaucoma. So in our app, we have discussed few studies. Please read glaucoma from the app. Okay, I've told you many things about the studies. We have discussed genetics also there. So please read that topic from the videos. Okay, very important. Okay, chala, let's move on to something in cornea, guys. What is this picture and what is this interpretation? I'm just magnifying this picture again if you have not attempted in the test. So again, what is this test and what is this interpretation? So I would say the correct answer here is, this is a normal cornea, normal curvature of the cornea by Placido disc test. So this is the correct answer, guys. Now, let us talk about what is a Placido disc, why are we going to do the test, what do we see on Placido disc, and what is this pentacam. Let us discuss these questions from the cornea. Okay, now guys, can you see this? This is a small appliance for clinicians. Yani ke, you know, even I have a small clinic. I don't have all the machineries. Like, I can't check curvature at my small clinic. So what do? I have a little small Placido disc. So what do I do here? This Placido disc, if you can see, guys, this has, you know, a series of white and black rings. And if you see it carefully, this has a central aperture, central hole. So what I'm going to do through this, I'll hold the Placido disc now and I'll go to a patient in whom I want to check the curvature. Okay? So what I'm doing, I see the reflection of this Placido disc in the patient's cornea. Okay, if you look at me, my picture will be there in your cornea. Yes or no? You will see a small miniature me in your cornea. Hai na? So what will I do? I'll see the reflection of this Placido disc in his cornea through the central hole. Okay, so I'm looking like this, right? Now, if my patient has a normal curvature of the cornea, I'll see the rings in his cornea like this. Isn't it? I'll see the rings like this. Okay. But suppose if the curvature is not accurate, what will I see then? I'll see some kind of irregularity in the curvature in the patient's cornea through the hole. Okay, so this gives me a sense of diagnosis that somewhere there is a problem in the curvature. Yes or no? The curvature is not normal. The curvature is some kind of defect. Okay, now, is this going to diagnose keratoconus? Yes or no? Is this the confirmatory test for keratoconus, guys? I would say no, absolutely not. Why? Because Placido disc, guys, is only telling you about the anterior curvature. It only tells you whether the curvature is normal or not normal. It's not telling you anything else. So, what do I do? Hanji, Dr. Abhilash, yes. It is telling you something about keratoconus, but it's not giving you a diagnosis for keratoconus. Okay, so what I'm going to do? So guys, this is the favorite question, Munson sign of keratoconus, where you see the notching of the lower lid. Okay, I have certain signs by which I'll think the patient has a keratoconus. Okay, now, but when I have to diagnose this completely, when I want to diagnose this, what will I do? I'll do another checkup which is called as pentacam. So friends, through the pentacam, I will be looking at everything. What everything? I'll have a color coded map. This is the color coded map where I will get every information about the cornea. I'll get to know what is the topography of the cornea. So if you see this carefully, bache, at every point it is showing you the curvature of the cornea. Can you see? Somewhere it is 44, somewhere it is 42, somewhere everything. So curvature can be seen. Now the other here graph, other color picture is going to tell you what is the thickness of the cornea at every point. So anterior thickness, posterior curvature, everything you will get to know from pentagram, which is called as corneal topography. Okay, so what is the information given by pentagram? This tells you everything about the cornea. We call it corneal topography, and this is the diagnostic investigation of choice. Okay, for keratoconus, please remember this is the diagnostic investigation of choice. Or for any other disorder of cornea where you are suspecting an abnormal curvature. It's not only keratoconus, we have certain things as well. Okay, now quickly discussing various important points about keratoconus, because I think again this topic is very important. Okay, so I'm telling you, just listen to me very carefully. Keratoconus is nothing but the disorder which is idiopathic. It is seen more commonly in young females, say about 20-22 years of a female. Here there is a progressive conical shape of cornea which is increasing, and here you will get a thinning of the cornea as well. Now the patient comes to you with complaints of frequent change of glass number. When you see the patient, you see various signs like Munson sign, which is notching of the lower lid. Cornea becomes thin, so your nerves becomes more prominent. You have a oil droplet sign. When seen through the ophthalmoscope, the nerves are becoming prominent. You have a Fleischer's ring, that is iron deposition at the base of the cornea. We also have Vogt striae. These are the vertical stress lines on the surface of the cornea. These Vogt striae are to be differentiated from the Harb striae, which are horizontal stress lines on the cornea. Okay, so Vogt striae versus the Harb striae, again a very important topic, right? So this is something about keratoconus, a very important topic for any exam. Okay, now guys, we expected a question on COVID, but we didn't get in our PG entrance exam. So again, we can expect something from the COVID this year. So what is the most common adnexal or orbital involvement of COVID? Anyone? What is the correct answer here? So kindly do not say mucormycosis. I would say this is one of the rarest involvement of COVID. The most common adnexal or orbital involvement of COVID is rather dacryoadenitis. What is dacryoadenitis, bache? Dacryoadenitis is nothing but this. This is an inflammation of your lacrimal gland. Do not confuse dacryoadenitis from dacryocystitis. What is dacryocystitis? This is the inflammation of the lacrimal sac. Okay, when your sac is inflamed, this is dacryocystitis. This is your acute dacryocystitis, and this one, the painless one, is a chronic dacryocystitis. Okay guys, so again coming back to our question, the most common adnexal or orbital involvement of COVID is dacryoadenitis. Perfect. Now something more related to COVID and I'm quickly telling you, listen to me carefully. So the most common ocular presentation of COVID is a conjunctivitis, an acute follicular conjunctivitis, right? Adnexal, I've told you, it is dacryoadenitis. Now, what is the most common cause of loss of vision in COVID? Anyone? The most common cause of loss of vision in COVID, what can be that? So loss of vision, please guys, it is not by mucormycosis, this is by arterial occlusions like CRAO and CRVO. Okay, so these phenomenon were found more commonly in COVID rather than mucormycosis. Okay, I hope this is clear to everyone. Alright, so mucormycosis treatment, you know, we have to give amphotericin B. If not treated, exenteration would be done, right? So this is something about your COVID and very important topic. Now, let's move on to CST, cavernous sinus thrombosis. Why? No, better, no. It is your occlusions, CRAO and CRVO, the occlusions. Okay? Chalo. Now let's talk about something in refractive surgeries. What is smile? So smile is, you should keep on smiling always. Okay, so here we are talking about the refractive surgery, and smile is nothing but small incisional lenticular extraction. Okay, what is smile? Small incisional lenticular extraction. So I'll briefly explain you what is happening and why this change. Why not LASIK? Why we are not very happy with LASIK? Arey, please don't be sorry, yaar. We are all learning. ठीक है ना? Okay. Chalo. So what is SMILE? Small incisional lenticular extraction. What is it? Let us learn. So guys, what is LASIK first of all? In LASIK, what are we doing? In LASIK, we are creating a flap. Okay. Suppose if this is your cornea, so we are creating first of all a flap, a superficial flap that would be raised like that. And this flap is now consisting of a little epithelium, Bowman's membrane, and a very superficial part of stroma. Okay. Then what will happen? Your excimer laser will come, and excimer laser will decrease the thickness of the cornea by the desired amount. Okay. So this is your brief LASIK procedure. Now what is the problem with LASIK? Why are we finding out the new procedures? Why? So guys, whenever we do LASIK, we are making a flap. Okay, like this. We are making a flap, right? Now by making the flap, we are actually cutting the cornea and making a flap by making such kind of incision which is like 20 millimeters broad, isn't it? Now when you make this, guys, no matter how good your surgery is, theoretically at least you are doing some kind of damage to the cornea, right? And when you do that, you are traumatizing your corneal nerve endings. So a problem of dry eye every time relates to the patient. Yes or no? Dry eye is always there a problem. Now to get a sophistication in our surgery, we are moving to surgeries which give us less side effects. I am not talking about superiority of results. Please remember, the results are comparable here. The results of RELX, SMILE and LASIK are almost the same. But what is improvised here? What are we doing here in RELX, SMILE? This is a bladeless and a flapless procedure. So we are doing a all laser procedure. Let me tell you how. Okay. So RELX, SMILE is nothing but SMILE. So what are we doing here? Instead of making a flap here with a microkeratome or a laser, we are making a very small incision which is just 2 to 3 millimeters thick. This incision is also made by femto laser. Okay, you press a button, a small incision which is like the shape of a smile is made at the level of the corneal epithelium. Okay, now what will we do? We will be preparing a lenticule of the desired thickness, what I wish to take out. Suppose I want to take out around 30 microns from the patient's eye because I want to correct his 2 diopters of myopia. Suppose I am taking an example. I want to correct minus 2 diopters of myopia. So I will be taking out 30 microns from the patient's cornea. So I am not putting excimer laser here. I am preparing a lenticule within the stroma of the cornea. And I will be now taking out that desired lenticule out of the eye like this. Please see everyone. So this is the procuring out of the desired lenticule of the desired thickness. Now, what is the advantage here? I have not made any flap, okay? And also, I have not made incision through the blade. The incision is made through the femto laser, and this is a flapless procedure. So what is the added advantage? The flap related complications are absolutely gone. The incision is very small. So what about the dry eye? The dry eye part is very less. So I would say it is very much complication free. Okay friends, again I am telling you, please remember, SMILE and your LASIK results are almost the same. But the question of side effects are very less in SMILE as compared to LASIK. Okay, I hope you have understood this, guys. Last year we had a question on refractive surgeries. They had given you a question on ICL. So now they can also ask you something about RELX, SMILE or LASIK or any other thing in refractive surgery. So please remember that becomes a very important topic. Okay, chalo. So now let's talk about something simpler. We have a young man here who comes to us with redness and pain, photophobia. So again we have complaints of redness, pain and photophobia. When you examine, you saw the pupil was small but it was reacting to light, okay? The circumcorneal congestion was also there. When you examine the patient, there's also a non-productive cough, okay? So cough is there. He also told about his tender nodules on shin. Now, chest X-ray also showed you bilateral hilar lymphadenopathy. So just forget about the choices. What differential have you got? Okay, forget about the choices. Just not look at the choices here. What differential diagnosis comes to your mind when the patient has a productive cough, the tendon nodules on the shield, on bilateral hilar lymphadenopathy? So guys, first of all, the only thing which comes to my mind is sarcoidosis. Yes or no? The very, very typical presentation of a patient of sarcoidosis, right? Now, when the patient have sarcoidosis, can the patient also have uveitis? Yes, of course. Okay, so sarcoidosis and uveitis can happen together. Okay, so the correct answer to this question is uveitis. Okay, clear friends? It's a very simple question. Uveitis topic, though it is small, but it has so many systemic associations, so you must remember. Now, briefly discussing the causes of uveitis. My first question to you is what is the most common cause of uveitis? Anyone? So the most common cause of uveitis is, I don't know what is the cause. The cause is idiopathic. Please remember, more than 60% of the patients of uveitis, the cause is unknown. It's idiopathic, right? Exactly, yeah. So 60 to 70% of the patients, the cause is unknown. We are not able to find out what is the cause, okay? Apart from that, we have a HLA-B27 related arthropathy. So HLA-B27 related arthropathies, what is the mnemonic here? PARI. What is PARI here? Psoriatic arthritis. A is ankylosing spondylitis, R is Riter's disease, and I is inflammatory bowel disease. Okay, so please remember HLA-B27 related arthropathies are very important. Apart from that, the third one is granulomatous disorders like tuberculosis, sarcoidosis, etc. Then we have JRA, juvenile rheumatoid arthritis, which is nothing but the most common cause of uveitis in children. Then skin disorders, allergies, connective tissue disorders, etc. So anything as a systemic problem can result in uveitis. But please remember, the most common cause of uveitis remains idiopathic, right? Chalo guys, a simple but a very interesting question. So we have a 65-year-old female who developed a red mark on white of her eye. You can see the picture very well here. When she got up today morning, she could not recall any history of trauma in the last 2 days, but definitely she is known to be hypertensive and diabetic for last 15 years. When you check, the vision was absolutely normal in both the eyes. So what is not correct about her condition? Please remember the word what is not correct. Okay. Now looking at this patient, can you make a diagnosis of a subconjunctival hemorrhage, guys? This is nothing but a subconjunctival hemorrhage. Okay. So systemic checkup should be done, of course friends, because hypertension is one of the most common causes of subconjunctival hemorrhage in elderly people. Okay, so please check up whether the systemic indices are okay or not. There's no use of giving NSAIDs, of course guys, this is not a painful condition, so you're not giving NSAIDs. Rather, NSAIDs can increase the chance of rebleed, so please avoid NSAIDs, do not give. Okay, now if the episodes are recurrent, you should investigate the patient. Of course, this is also correct. Now, every other day the patient is having this kind of condition in the eye. It is your responsibility to check whether there is something wrong going to be with the patient or not. Okay, find out the systemic problems in the patient and check out whether there is some kind of bleeding problem or not, coagulation disorders, bleeding disorders or not. Okay, so this is again a correct statement. So self-resolution in 5 days else needs further investigation. So I would say this is incorrect statement, because definitely for the patient self-resolution occurs but not in 5 days. You must give the time period for 2 to 3 weeks to the patient. It may take 2 weeks for this problem to get resolved. Alright friends, so this is a very, very important topic. Please remember. Now, whenever we have such kind of patients, we try to elicit the history. What is the cause? So I would say the most common cause of subconjunctival hemorrhage is trauma. But if there is no history of trauma, it has been spontaneous. Elicit the history of hypertension. Find out whether the patient has a blood or coagulation disorder. Patient has been coughing. There's a pertussis, whooping cough or not. or any other problem to the patient, maybe vicarious menstruation, straining during stools, or some kind of viral hemorrhagic conjunctivitis. Now, how to treat? So as I said, it is self-resolution is the treatment. You can also give vitamin C for quick or hastening of the resolution of the blood. Okay, apart from that, we don't have any other treatment, right friends? Now guys, this is a little controversial topic because recently we have got so many queries on this one as well, because some sources mention the correct answer is cataract, some sources mention the correct answer is glaucoma. So what I have gone through, what I have read very recently again, this is the correct answer to this question should be a cataract. Okay, the correct answer to this question should be a cataract. Okay, now I'll explain you what I have read and what I believe is correct. And I would say definitely it's a controversial topic, so maybe the controversy still remains. Okay, so guys, when they talk about the problem related to anterior uveitis, only the word anterior uveitis, I think most of the patients of anterior uveitis land up with a high IOP. Okay, common sense. Why? Because when you have anterior uveitis, you have cells, you have inflammation. So IOP is supposed to be rise because of inflammation. I'm not talking about synecdoche. I'm not talking about a secondary angle closure glaucoma. I'm talking only about a high IOP because of inflammation in the eye. So agree. So I would say glaucoma or high IOP happens when you have any case of anterior uveitis. This is found to be the most common complication of anterior uveitis. But when I talk about recurrent anterior uveitis, when you have recurrent episodes of anterior uveitis, it is most likely to cause a cataract. See, I am not denying that glaucoma cannot happen. A glaucoma, which is a secondary angle closure glaucoma, can also happen because of recurrent anterior uveitis. But if we talk about the comparison, cataract and glaucoma, a secondary angle closure glaucoma, cataract is more common. Okay, so now I hope that you've understood what is the problem here, what is the controversy here. So this is what I believe is the correct thing. Now friends, in anterior uveitis, you can have a secondary open angle glaucoma because of inflammation. You can also have a secondary angle closure glaucoma due to the synecdoche formation. So please see a patient who has anterior uveitis. Guys, please see. So can you see those mutton fat KPs which are arranged in a arched triangle form? You see the pupil is small and pupil is irregular. Okay, so this is a characteristic pupil of anterior uveitis. Okay, so you can also have a hypopion here. You can have these mutton fat KPs which are arranged in a slit in inferior part of the cornea. When you dilate such pupil, you get a festoon pupil, irregularly dilated pupil, very commonly asked question. And the secondary angle closure glaucoma in such patients is because of this. Why? Because the iris is now in a Bombay form. What do we call it? Iris Bombay. Okay, so this is the one which is the culprit. This leads to a secondary angle closure glaucoma. Now, why the iris Bombay develops? It is because of the posterior synecdoche. What is posterior synecdoche? It is nothing but the adhesion between iris and lens. Okay, so we have lot of adhesions between the iris and lens. So I would say this is seen in recurrent cases. Okay, very less do you see this in acute cases. So secondary angle closure glaucoma is of course in recurrent anterior uveitis. But if you see the frequency, cataract is much common as compared to a secondary angle closure glaucoma. Alright friends, this is important. Chalo. Now let's move on to the next one. So a 60-year-old male who came to you with painful red eye. He has a history of phacoemulsification 6 months back and now he is having a decrease in vision. On examination, his vision was finger counting close to face. There is a vitreitis and anterior uveitis. There is a white plaque also. So what is this suggesting? Now, what do you think is the most likely management you would do? So friends, just looking at the question, I have made a diagnosis of a late onset endophthalmitis. Okay, isn't it? Late onset post-operative endophthalmitis. Okay, Why late onset? Because look at the history. So the patient has a history of phacoemulsification 6 months back. Generally, guys, in our previous examinations, questions on endophthalmitis have been there. Yes or no? We have got so many questions on endophthalmitis. But those are acute postoperative endophthalmitis. Here I have twisted the question and I have given you a question on a late onset endophthalmitis. So, first of all, what is the definition? The definition is any endophthalmitis which occurs after 6 weeks of surgery. So after 6 weeks of surgery, what do you get? You will get a late onset endophthalmitis. ठीक है बच्चे? Now, why I am saying you that this is a case of endophthalmitis? Because definitely the patient has a decrease in vision and he also has a vitritis and anterior uveitis. So, what is the definition of endophthalmitis? It's nothing but a severe inflammation of the inner contents of the eye. So you have inflammation in the anterior chamber, you have the inflammation in the anterior segment as well as the posterior segment. What is not infective, what is not inflamed is your sclera. Your sclera is not inflamed. Okay friends? Now, what is the significance of white plaque here? What do you suspect here? Which microorganism is there? The microorganism should be Propionibacterium acne. So this is the one specifically which gives you a plaque at the IOL. A plaque at the IOL. Okay. Now, once you have this P. acne, Propionibacterium acne, as the causative organism of the postoperative endophthalmitis, guys, the treatment, the best treatment should be a pars plana vitrectomy, removal of the IOL, and followed by a intravitreal antibiotic in the same sitting. Now friends, please remember, whenever you have endophthalmitis by Propionibacterium acne, we do not expect that it would be treated in the same way as our acute postoperative endophthalmitis by staph epidermidis would be treated. Okay friends, staph epidermidis responds very well to a intravitreal antibiotic, but P. acne does not respond much. So here in those cases you must do a pars plana vitrectomy, and because the IOL has got a plaque, so you must remove the IOL also. Later secondary IOL implantation could be done, but in the primary setting we just do a vitrectomy, give an intravitreal antibiotic and remove the intraocular lens. Okay, so this is important as a question, very important one. Okay. Now, how do you see a patient of endophthalmitis, guys? Because you have inflammation all around, so this one is the characteristic hypopaeon. This is nothing but your pus in anterior chamber. Okay, guys? Important one. Chalo, so let's talk something about the ROP. So I'm sure that while reading the question, you are able to diagnose that we are talking about the retinopathy of prematurity patient, because you have all the the clinical scenario is like this. So the baby has been born in less than 34 weeks of gestation. Okay, this is one of the risk factors, right? Now, I have given you a very typical question. If the patient is born in less than 34 weeks, okay, you must do a screening of ROP. But when should be the first screening? So I'm asking you, when should be the first screening done? Now, so how to remember, friends? How to remember? So if the child is very small, less than 28 weeks of gestation, we should examine him early. We should examine him early. That is within 2 to 3 weeks of birth. Within 2 to 3 weeks of birth. But if the baby is a little bigger, that means 28 to 34 weeks of gestation, we can examine him late. How late? After 4 weeks of birth. Okay friends, please remember, this is a very important topic, when to do the first screening. If the baby is really very small, screen him early. If the baby is little bigger as in 28 to 34 weeks, then you should do a screening later on after 4 weeks of the birth. Now, we already have a 2-week child. We already have a 2-week child. So when should you do the examination? Because he lies down in 30 weeks of gestation wala, so we will be doing the screening after 2 weeks from now. Okay, after 2 weeks from now. So there is a twist here. I hope you've understood what is the twist here. Have you understood what is the twist here? So this is a baby which is lying down in this age group. The screening should be done after 4 weeks of birth. So already we have a 14-day baby. So when should be the screening done? After 2 weeks from now. Okay, after 2 weeks from now, this should be the correct answer. I hope that's clear to you. Okay? Chalo. So a similar question, I told you refractive surgeries are a very important topic. I want to discuss something about the intracorneal ring segments. What is ICRS? Intracorneal ring segments. So guys, in the app we have discussed refractive surgeries as a separate topic, and I request all of you should go through that topic. Refractive surgeries is one of the important topics nowadays. Okay, we are expecting one question from that. So before you go to your exam, please read from that video. That will be really helpful. Okay, so what about this intracorneal ring segment? So first of all, see what is intax. Intax is nothing but a type of ICRS. Okay, do not get confused, both of them are same. Intracorneal ring segments are mainly of 3 types. Don't go much into details, just remember intax is one of them. Okay bache, now what are we doing here? Please see that we have implanted 2 semicircular rings like this within the stroma of the cornea. So how we have done that? So this is with the help of femtolaser. Okay, femtolaser will create the incision and you can just place these 2 intracorneal ring segments like this. Now what is the use? So friends, first understand this is made up of PMMA. Okay, they are made up of PMMA, and depending upon the material and the various dimensions, we have 3 types of ICRS, right? Now what is the use? So guys, they flattens the cornea. They corrects all irregularities of cornea. So where are we requiring that? We can use this in the treatment of high myopia, where LASIK cannot be done. Suppose a patient has a very high power, -10, and the cornea is already little thinner, and we cannot do a LASIK here. So in such cases we can put a ICL, and what in such cases we can give a intracorneal ring segment. Apart from that, we can correct the irregularities of the cornea in keratoconus patient as well. So guys, in keratoconus, rather this is the treatment of choice for a stable keratoconus. For cases where keratoconus is not now progressing, it is now stable, we can put ICRS. So let's go back to our question. Does it made up of PMMA? Yes, of course, it's made up of PMMA. It is used in keratoconus. Yes. Friends, is it a reversible process? Yes, of course. This is again an advantage over other refractive surgeries. Once you are done with LASIK, you cannot redo it. I mean, you cannot undo it. Not redo, but you cannot undo it. Same goes with other surgeries. If you are done with one surgery, you cannot undo it. But this one, these are some implants, you can also take them out if you have a problem. Okay, so this is a reversible procedure. But can it be used for dystrophies? Absolutely not. So this is the correct answer. For corneal dystrophies, we do not need that. We will not use that. Understood? Now, a simple question, but I've made, the choices I've made just a little difficult. So please see what following are seen in pterygium. So is there a destruction of Descemet's membrane? Absolutely not. It does not go to the Descemet's membrane. Rather, it will just go towards the Bowman's membrane. So P53 normal activity? No. I hope you remember that pterygium occurs because of stem cell deficiency in people who are mostly exposed to UV rays. Why? Because there is a problem with the P53 also. There is a P53 mutation or some problem with this kind of gene. Okay. So hyperplasia of goblet cells? Absolutely not, guys. Goblet cell hyperplasia is never seen in this condition. But what is the main problem in pterygium? So this is the problem. There is a elastotic degeneration and hyalinization of the connective tissue of conjunctiva. Okay, so this is very important, as Dr. Illuminati has correctly said. Now, Many students get confused between pinguicula and pterygium, so I'll be quickly telling you. Pinguicula is a nodular elevation near the limbus. Now guys, many people consider pinguicula to be a precursor of pterygium. Why? Because in pinguicula also we can see the same thing. Elastotic degeneration and hyalinization of the connective tissue can also be seen in cases of pinguicula. Though the word pingus means fat and it is nothing but accumulation of fatty tissue. But if you see actually what is the problem, so there is a elastotic degeneration also in the subconjunctival tissue. Okay friends, now let us quickly discuss pterygium. Again, this is an important topic. So pterygium is a wing-shaped fold of conjunctiva encroaching on the cornea. It has a head, it has a neck, and there is a body. On the pterygium, many times we have a iron line accumulated on the head. We call this line to be Stocker's line. Now, once I want to treat pterygium, I can do a plain excision by lifting the pterygium and cut the pterygium tissue, but this is associated with lot of recurrence. So what do? We do an autografting. Autografting is nothing but excise the pterygium tissue and put a similar kind of same patient's autograft from the conjunctiva. So we do not want the sclera to remain bare. We don't want the sclera after excision to remain bare. So what do? This is called as autografting. Now friends, what is a perfect surgery? I want you to know what is perfect surgery. So this is an acronym of what? Pterygium extended resection followed by extended conjunctival transplantation. So they say when you are excising, you excise a little more. They say when you're putting a graft, put a little more bigger graft. So that is your perfect surgery. Important question in context of pterygium. Alright, remember this is an important topic. Now, a simpler question from anatomy. So what of the following is true about ciliary body except? So I'm sure you know that ciliary body is the middle part of the uveal tract, or it is the intermediate part of the vascular coat of the eyeball, that is the uveal tract, right? Now if we talk about ciliary body, it consists of pars plana and pars plicata, yes. Now you know that ciliary body also has ciliary zonules. So from the ciliary body, the zonules arises and zonules help us in accommodation. So ciliary muscles, zonules, they help in accommodation, yes. Now, we also are familiar about the secretion of aqueous humor. We know it is secreted from pars plicata. Now, what about the blood supply? So, is it by short posterior ciliary artery? Absolutely, this is a wrong question, statement. The correct statement would be from the long posterior ciliary artery. So guys, I'll show you some type of pictures by which you will come to know something in brief about the anatomy. You know we have anterior segment, the posterior segment. This part is your anterior, this is your posterior segment. You have ciliary body, which is a triangular cut section area. Anteriorly we have pars plicata and posteriorly we have a plain part. We call it pars plana, right? Now, what about the arteries here? So guys, this is a beautiful diagram by which you can understand it very easily. The choroidal arteries, right? We have the ciliary artery, the choroidal arteries. The choroidal arteries have two branches like long posterior ciliary and short posterior ciliary. Now common sense says the short posterior means they have a short root. So when they have a short root, they supply nearby the optic disc. They are short. They are not going anteriorly because they are short. So they supply the nearby area, and the nearby area is the optic disc, right? Now what about the long posterior? Long posterior, the common sense says they are long. So they will go a long way, like here. They come into the anterior segment and they anastomose with the anterior ciliary artery, which are the branches of muscular arteries, okay? So they communicate with the anterior ciliary artery and they form what? A major arterial circle. Okay, so important question. We have the major arterial circle, which is nothing but an anastomosis of anterior ciliary artery plus Long posterior ciliary artery. So this is again a question, guys. They ask you major arterial circle lies where? Anyone? Major arterial circle lies where? Anyone? So major arterial circle lies near the root of the iris, okay? Root of the iris, and this is the one which bleeds once you have hyphema. Okay, most common source of bleeding in hyphema, it's the major arterial circle, right? Chalo guys, another important expected question this year from retina. So a patient has flashes and floaters. In retina, this lesion was seen. So what is the treatment of this condition? What is the treatment here? Now, first of all, please diagnose this. Once you have a patient who has floaters and flashes, what comes to your mind? Maybe we are talking about a tear in the retina. Maybe we are talking about a RRD. Yes or no? We are maybe talking about a tear in the retina or a RRD. So friends, patient coming to you with floaters and flashes, and in the retina this lesion is seen. This lesion is nothing but the lattice degeneration, isn't it? Lattice degeneration. Yes, Dr. Illuminati, there is a difference between detachment and degeneration. So what is it? Detachment may be the last thing to happen. A patient may also have flashes and floaters because even of a lattice degeneration with a hidden tear. You may not have even a detachment as of now. Okay? So there is a difference here. You can have a detachment, you may not have a detachment. You may only have a lattice degeneration with a hidden tear, right? But definitely it can progress to a detachment. So what are we supposed to do? क्या करेंगे अब इसमें? क्या करेंगे? Will you do something? Yes, of course, guys. This is a prophylactic laser barrage. I would say this is a prophylactic laser barrage. Why prophylactic? Because detachment has not occurred yet. Okay. So detachment has not occurred yet, and we want the patient should not develop a detachment. So we will seal the particular tear, or you will do a laser barrage in 2 rows. We are doing lasers by either the argon or a double frequency ND-YAG. Okay, what are we doing here? We are making small spots in 2 to 3 rows around the area of the degeneration or around the tear, so that later on after 2 to 3 months this whole area becomes scarred. When this will become scarred, this will become sealed and detachment will never occur. Okay, so again going back to the question, what I want you to tell you first is floaters and flashes does not always mean that there is a detachment. Clear? You can also have a lattice degeneration or any other degenerative change in the retina which may have a hidden tear, right? So we can do a prophylactic laser barrage. I hope this question is clear now, beta. Is this question clear now? Arey, why are you guys sorry? There is no need to be sorry, bache. As I said earlier, we all are learning. We are here to make mistakes, right? Don't make mistakes in exam. Okay? The concept is important. You should learn the concept. ठीक है बच्चे? Later on this patient may develop a detachment, but as of now the patient does not have a detachment. He only has a lattice degeneration here. ठीक है? चल. Now what is this? Again a picture question. Now here the patient has a beautiful tear. This is your horseshoe shaped tear, and this is a detached retina. Now do you think the patient will only have floaters and flashes here? No. Apart from floaters and flashes, the patient will also have a decrease in vision or a field defect. So now my question may change. Now here, if I would have written decreased vision or a visual field defect, then you can think about the RRD. Alright, so this is how with symptoms your diagnosis changes. Now here spot diagnosis, what is the picture? Spot diagnosis, this is nothing but the KF ring. K is a Fleischer ring. Now we know everything about KF ring. We have discussed this very nicely in app also. So I'll again discuss quickly because this is again a very important topic for your exams. So Kayser-Fleischer ring is nothing but copper accumulation in the Descemet's membrane of cornea. You can see this in Wilson's disease, but it is not pathognomic for Wilson's because it is also seen in chalcosis, right? Now, this is not an irreversible ring. This ring can be reversed when you treat the patient, right? Now, earliest seen on gonioscopy. Dr. Sheikh, unfortunately, this is not the correct answer what you have said, because this is a correct answer. So, why I have intentionally given you the question? Why? I want to tell you another way of solving the question. Friends, we have read so many things about KF ring, so many things. But probably we do not know enough. We do not know that it can be seen on gonioscopy as well. So suppose your KF ring has just begun. When it begins, it only lies in superior and inferior part of the cornea. Later on, it becomes concentric. It is barely seen in the initial cases by slit lamp or even by the naked eye. So what are you supposed to do? You can do a gonioscopy. You can also do a anterior segment OCT. Okay, friends? So we have some more diagnostic investigations apart from slit lamp. You can do a gonioscopy. You can see a ring through the anterior segment OCT. But why again I'm keeping this question in this? Because I want to tell you that we cannot learn everything about every topic. But if we are sure about the knowledge, we know that the KF ring is an irreversible ring. KF ring is a reversible ring. We should be able to answer this question. Okay, so trust your knowledge, bache. If you know a fact, this should be the correct thing. Don't get confused by the fancy things we have in our questions. Okay, all right, Dr. Sheikh, convinced here? Convinced? Chalo. So let's talk about the next question, something very, very important from angle closure glaucoma. So we have a middle-aged female who has a refractive error of +2 diopter. So what is the significance here? I want to tell you the patient has a hypermetropia. Okay? Patient has a hypermetropia. The patient also has colored halos. When she went to see a movie theater, she went to see a movie in the theater. She developed a mild headache and there is eye pain on the right side. When she came to you for a routine checkup, you found the IOP is high. The IOP is 28 millimeters of mercury. And in the right eye and in the left eye, the IOP was borderline. So I would say the IOP is almost normal. But the gonioscopy showed narrow angle. So what should be the next step? So guys, I'm sure that you are fitting well everything with the angle closure glaucoma, isn't it? You are fitting everything nicely in a picture of angle closure glaucoma, right? Now, I'm not saying this is an angle closure glaucoma attack, but I'm saying the rest of the things are normal, but the patient only has symptoms with a high IOP. So, I am now keeping this patient in a diagnosis of angle closure. Okay? We can say the patient is in the stage of primary angle closure. I'm still not saying the patient has the stage of angle closure glaucoma. Okay? Now, what to do next? You have diagnosed the patient has a primary angle closure. So what I'm going to do? No, bache, no, wait and watch. No. This is the time when you should act. This is the time when you should intervene. You should do a YAG PI of both eyes. Why? No, bache, no, Chirag, no. So I think you guys are confused here. Let me tell you. So what are you waiting for? Tell me. The IOP is already high. The patient has symptoms. Patient also has the symptoms of colored halos, right? And this is developing since few days. Are you waiting for the angle closure glaucoma attack to develop? है ना? Because your IOP is already high in one eye, why do you want to wait? Do a YAG PI. Okay, this is your gonioscopy. You can see the angle is narrow, angle is closed. So why not to treat this patient, isn't it? So treat the patient by doing ND YAG laser. This is a very important picture question as well, guys. Make a hole in the mid peripheral part of the iris. Okay. Okay, Dr. Mohammed has said answer should be C. Why, bache? Why C? Why do you want to do a visual field analysis? Do you expect angle closure will have, acute angle closure will have a visual field change? Yes, beta. Hanji. So tell me what is in your mind. Let us discuss this topic if you are confused here. Do you really think visual field analysis will help here? Not much. You can do it, but I want to ask you what is the treatment here? Visual field analysis and primary angle closure does not really have a role. So you should intervene fast because the IOP is already high. Treat the patient by doing a YAG PI. Now why both eyes? So for right eye it will be therapeutic, and for the left eye it will be a prophylactic procedure because the patient is a anatomically predisposed patient. So you should be making, hi Dr. Chirag, I am answering the same beta. For right eye it will be a therapeutic procedure, but for the left eye it will be a prophylactic procedure, isn't it? Haven't we learned that PI would be done for both the eyes, bache? Haven't we learned that? Because the patient has the anatomically predisposing factors, so this patient can land up into attack any day in the other eye as well, isn't it? Convinced everyone why the answer should be D here? Tell me, you convinced? Okay, bache, it should be like this only. Chalo. Let's talk about something more interesting. Let us see if you have answered this correct or not. Okay. Chalo, ye dekho beta. So again we have a similar kind of patient, but now this time we have a male here, and there's a frequent change of presbyopic glass. So stop, everything stop. What is the only condition where you have a frequent change of presbyopic glass? So I'm sure you should be telling me about the POAG. Yes, the only symptom here is a frequent change of presbyopic glass, but the vision is absolutely normal. The angle is open. Now, you have checked the IOP is 20 on Goldman applanation tonometer. So you will say, madam, the IOP is normal. But what is the trick? What I have done? What is the tricky thing which I have done to the question? I have given you a thinner cornea. And I am telling you the CDR is also a high one. Yes. So visual fields are normal. What is the next step would you do? बच्चे मोहम्मद शहजाद वाई गुनियोस्कोपी नो PI इसमें क्यों करेंगे? We are talking about an open angle glaucoma. Do you do a PI in open angle glaucoma? No. We are discussing here a primary open angle glaucoma. Now, first of all, understand what the trick I have played here. I have decreased the central corneal thickness. This is not this normal central corneal thickness. Our Goldman applanation tonometer is being calibrated for 520 microns. If the patient has a thinner cornea, for a thinner cornea, this reading will be a false low reading. जो मैंने कैलकुलेट किया है बच्चे यहाँ पे, ये falsely low reading है. तो इसका IOP पेशेंट का almost 26-27 millimeters of mercury है. Why? Because we have to make a correction. We will make a correction. So what is the correction factor? Learn that, guys. Please learn that. So for every 10 microns of thickness or thinness of change in the central corneal thickness, we should add 1 millimeters of mercury in the reading. मतलब क्या देखो बच्चों समझो. So if the CCT is 520, I will consider 20 millimeters of mercury to be the same. But if I have a thinner cornea, I'll make some correction. What is that correction? Please everybody see. So 520 में से 450 minus किया, that will become 70 microns. So my patient's cornea is 70 micron thinner than the normal cornea. So what will be the correction factor? For every 10 microns, 1 millimeter. So if I have checked it to be 20, the corrected IOP value would be approximately 27 millimeters of mercury. Please remember, this is a very important question, especially for INI CT. Okay, the corrected IOP would be high. Now, can anybody tell me what should be the answer now? We have a high IOP patient. We have open angles on gonioscopy. We have the complaint, frequent change of presbyopic glasses. So what are you going to do now? I will start directly with the anti-glaucoma drugs. Okay, I do not plan or repeat this after 1 year. No, I will start him on treatment because the IOP is already high. Okay, friends, so this is how we have to solve such questions. Please remember the CCT is important. If CCT is not given, you may wait, because here 20 is supposed to be normal, you can wait. But if I have given you a thinner cornea, that means patient is already running with a high IOP. In such cases you should treat the patient. Okay bache, everyone please show me a thumbs up if you have understood this. A simple question is this: you have a you have a big large vanda cup. This is a high cup to disc ratio. I think this is clear, everyone, right? Chalo, let's talk about something from cataract. For what is this sign? This sign ensures what? So I'm sure everybody knows that this sign is the famous golden ring sign, isn't it? This is the famous golden ring sign. Golden ring sign. So where do you see this golden ring sign? This is a sign of a complete hydrodelineation. So let us understand what are the topics, what are the questions here from cataract surgery. So everyone please see, this is a step, another picture question. This is a step of anterior capsulorhexis. You can do opening, you can make a opening in the anterior capsule, the anterior capsulorhexis. Later on we'll do hydro procedure. What is hydro dissection? This is nothing but injection of a fluid weight under the capsule to separate the capsule from the cortex. Hydro dissection. Some surgeons like me, I always do a hydro delineation, especially for softer cataract. So what do? And inside the lens, under the capsule, I will do another, I'll inject another fluid wave that is slightly inside the capsular area. So that is going to give me a cushion. Okay, so this separates the outer nucleus from the inner nucleus, or you can say separation of nucleus from the cortex. Okay friends, so when you see a golden ring sign, that means your hydrodelineation is complete. That means this one is your inner nucleus and this is your outer cortex, which is now separated. Okay, so what is the use of that? It gives me a sense of feeling that my nucleus is now safe. There is a cushion overlying the nucleus behind, so that I can do my phacoemulsification without the risk of tearing off my posterior capsule. Okay, don't get confused here. There are two different steps. Hydrodissection is different from hydrodelineation. Delineation is nothing but separation of nucleus from the cortex. Okay friends, this is important, right? Chalo everyone, another set of important expected questions. Can you identify this lens? Yes friends, can you identify this? So this is a very famous lens. This is called as accommodative lens. The prototype is Crystal lens. Crystal lens. Now guys, what we put commonly, the most common lens used in cataract surgery is monofocal lenses. Monofocal matlab they correct only for distance. Okay, unifocal monofocal lenses. But for somebody like me, suppose when I get a cataract surgery, I will not be very happy using a near vision glass. Okay, I probably would be somebody who does not want to wear a near vision glass. So for me, what can be the options? I can either use a multifocal intraocular lens. What is multifocal? You have various segments. Okay, can you see the various rings here? So every ring corrects for a different focal length. Okay, multifocal intraocular lens. You also may have accommodative lens. So what is the use of this lens, bache? Whenever you want to look for near, there is some kind of anterior movement of the optic. The optic moves slightly anterior. It is so arranged that it corrects little for near vision also. Okay, so this is some kind of advantage over the monofocal lens and multifocal lenses as well, right? So these two lenses are very important for your exam point of view. Multifocal and accommodative lenses. Please read them from the app also. Intraocular lenses is also a very important topic, right? Chalo. Now let's move on to something which can be there in your exam, because few years back guys, you had a question on enlarged blind spot. You remember? Enlarged blind spot, and there you had an option of something from this. Anyone, what is the answer? So what is the characteristic optic disc appearance? This characteristic optic disc appearance is called as double ring sign. So what is this double ring sign, bache? If you see carefully, you will find out two rings here in the optic disc. So this is characteristically seen in patients of hypoplasia of the optic nerve. Now guys, we mean hypoplasia to be less number of ganglion cells in the optic disc. Okay, we know that optic nerve is made up of ganglion cells, so we have lesser number of ganglion cells in the optic disc. Now hypoplasia of the optic disc characteristically will give you double ring sign, where the outer ring tells you the junction between sclera and lamina cribrosa. The inner ring is nothing but the normal extension of the retinal pigment epithelium, right? Now what important thing you have to learn? So friends, double ring sign first of all is seen in hypoplasia of the optic nerve, and hypoplasia of the optic nerve can be associated with a very dangerous syndrome we called is de Morsier syndrome. Okay? De Morsier syndrome. So what is happening in de Morsier syndrome? You have complete absence of septum pellucidum. Normally we have a septum pellucidum here, but there is a complete absence of this. So this can be a expected question in your exam. Very good, Dr. Chirag, absolutely right. So this is your double ring sign of hypoplasia of the optic nerve. Okay friends, please remember important topic. So something again from glaucoma. Let us see now if you can crack it, because most of you were confused from questions of glaucoma. Let us see this one. Chalo. So there we have a 60-year-old female who complains of frequent headache since 2 years. Okay. CT scan was normal. So patient also got a CT scan done. Now she has come to you for ophthalmic checkup quite late, I would say. Since 2 years she hasn't come to us. Anterior segment is normal, but IOP was 18 millimeters in both the eyes. So IOP is supposed to be normal also, isn't it? When you checked the cup to disc ratio, I would keep this as a suspect one. Okay? Gonioscopy revealed an open angle, but when you did visual fields, you found out scotomas. So you had a sedal scotoma, you also had a paracentral scotoma in left eye. So what is your diagnosis here, guys? It's a very clear-cut question. My correct diagnosis is a normal tension glaucoma. Isn't it, friends? Can this happen? Yes, of course. So guys, frequent headaches, probably the patient is predisposed to have migraines. And normal tension glaucoma patients definitely have migraines, Reynolds phenomenon, and some kind of problem in the body which may lead to decreased or poor vascular perfusion pressure at the optic nerve head. Okay, so please remember this is a perfect question for your normal tension glaucoma. Okay, I'm sure, yes bache, absolutely correct. So you know everything is fitting up very well in case of normal tension glaucoma, right? Now here I could have given this to be 0.8 also, right? Now my next question to you, Mohammad Sizad, aap batao bache, so what is your next step in management? What do you do? Okay, you have diagnosed the patient has NTG. What is the next step? What do you do? क्या करोगे बेटा? So you will further lower down the IOP. Okay, this is the treatment. I'll start with the drug of choice. So latanoprost is also the drug of choice for normal tension glaucoma. I'll set a target pressure for her. Maybe I'll keep the target pressure of 12 to 13 millimeters of mercury for her. Right? That will be my target pressure. Okay. I will lesser the IOP with the help of latanoprost, right? Latanoprost is a drug of choice here. I may also add some kind of neuroprotective also here, okay? Now, important topic, what is gun sign? So, gun sign is nothing but tapering of veins on either side of the crossing. So, what is it? Let us talk about this. So, normally guys, if you have the vein and if you have the artery here, vein, I'm sure you know, vein is little more dilated as compared to the retinal artery. Okay, so we have AV crossing junctions. Now here in AV crossing junctions we see three type of the changes in hypertensive retinopathy: Salus sign, gun sign, and bonnet sign. So what is this famous gun sign? Let us see. Now if this is the normal artery, this is the normal vein. In gun sign, gun is like this. I'm sure you must have seen guns. Guns are like this. So the vein take a shape of a gun. It shows you tapering at either end. Okay, this becomes a tapering of either end. Okay, so this is your famous gun sign, where at the site of AV crossing areas in hypertensive retinopathy, you see tapering of veins on either side. Okay, Chalo, a simpler question. Yes, everybody know that this was hypertensive retinopathy. Now a simpler question. We are talking about something in diabetes. So we have a 53-year-old man with type 2 diabetes and we saw NVD. What is new vessel formation at the optic disc? This is nothing but NVD. Vision is not so affected. Vision is almost the same. BP is almost this, the normal, and this is a little high as expected. This is a little high. So what is the most probable intervention? What is the most important intervention? So guys, common sense. What is the treatment of PDR? What is the treatment? Lasers, isn't it? What will you do? We will start do a PRP. Okay friends, we are talking about NVD here. Though the patient's vision is normal, what if the patient's vision is normal? It's definitely an indication of treatment. So we will be doing a pan-retinal photocoagulation. Okay, now let's see the picture here. This is your NVD, new vessel front at the disc. What are we going to do here? We are putting the laser marks all over the retina except the macula and the optic disc. Macula and optic disc are two areas where we'll never do the lasers, right? Pan-retinal photocoagulation. Now, see this question again, a very important expected question. So there is a patient who has a history of hypermature cataract. Dr. Chirag, no bache, not correct answer is not C. If we have in the question PDR, PDR is an indication of treatment. Okay, beta, Dr. Chirag, right? Chalo, so we have a patient who has a history of hypermature cataract. Now there is a history of 2 days ciliary congestion, photophobia, and there's a deep anterior chamber in the right eye. Now what do you think is the diagnosis here? What do you think is the diagnosis? There's a deep anterior chamber, so phacomorphic glaucoma is absolutely out, right? There's a deep anterior chamber, that is why I would say the diagnosis here is phacolytic glaucoma. So what is the context of hypermature cataract here? Let us talk about it. So this is nothing but your HMSC Morganian cataract, okay? HMSC Morganian cataract. I'm sure you know the typical famous bag of milk appearance where the nucleus has gone down and there's a rupture in the anterior capsule, your lens proteins leak out. Now, a patient who had a hypermature Morganian cataract later on can develop a phacolytic glaucoma. Why? Because of blockade of the trabecular meshwork by the ruptured protein capsules where the proteins are leaking out and getting accumulated in the trabecular meshwork. Okay, so the deep anterior chamber is giving us a clue. Okay, now in cataract patients, do we expect a ciliary congestion? No. We do not expect a ciliary congestion. We do not expect a photophobia. But why is it developing here? Because here now the IOP is rising. Okay. Maybe in a day or two the patient will come to you with a lot of pain also. Right. So this is the diagnosis of phacolytic glaucoma. Now a very simpler one. But I just want to tell you that anti-glaucoma drugs is one of the most important topics in ophthalmology. So you must go through all the anti-glaucoma drugs, read the side effect very, very nicely. Okay? Side effects and everything on anti-glaucoma drugs you have to read. Bache. Very, very, very important topic, right? Chal. So anti-glaucoma drug which can be safely given in pregnancy, the only one is brimonidine. So brimonidine comes from the family of alpha agonists. Brimonidine has dual actions. It decreases the IOP by decreasing the production of aqueous. It also increases the uveoscleral outflow. So brimonidine crosses the blood-brain barrier. That's why it causes sedation in children. So we try to avoid it in children. It is contraindicated in small children because of sleep apnea. Redness and hyperemia is the most common side effect. Though it has so many problems, but it can be safely given. The only drug found safe to be given in pregnancy, right? Please remember that one. So from our ALIGHT test series number 1, the last question here is this. Something very important from xerophthalmia, okay? So we have a small boy living in a remote village presented with his mother in OPD with difficulty in vision during evening hours as explained by mother as frequent falls during his playing hours in the evening. So frequent falls during his playing hours in the evening means what? The patient has a complaint of night blindness. Yes or no? Now when you examine, the patient's vision was normal but anterior segment showed this picture. So can anybody tell me what is this picture? What is this picture? So guys, please do not say it is bitot spot. Please. Bitot spot comes late. This is a picture of conjunctival xerosis. Please remember, conjunctival xerosis is the first sign of xerophthalmia, right? Bite spot comes late, though it is a very significant sign, a very specific sign, but it comes late. And bite spots look right like this. Okay? So this is collection of keratinized desquamated epithelial cells mixed with gas forming bacteria, the Corynebacterium xerosis. That is why the foamy appearance of the bite spot. Please remember, this is not bite spot. This is the dryness of the conjunctiva which we see under slit lamp. We can also stain the conjunctiva by the rose Bengal dye. Okay friends, again, this is not a picture of bite spot. This is a picture of conjunctival xerosis. Now let's read the option. Let's see what we have in the options. Indirect ophthalmoscopy should be done to see the retinal changes. Yes guys, because we may have a xerophthalmic retina. The retinal pigmentary changes may happen because the patient has a complaint of night blindness. So yes, this should be done. Ask for his immunization history. Yes friends, why not? Because xerophthalmia can happen if the patient is not immunized properly. The patient can has a vitamin A deficiency as well. The earliest sign for this condition is conjunctival xerosis. So I would say this is also a correct thing, because here you do not have a bite spot. This is only a dryness of conjunctiva. Now vitamin A 1 lakh international unit should be given orally to him stat. Now this is an incorrect statement. Why? Because the correct dose should be 2 lakh international unit. Please remember, a child who is more than 1 year of age or more than 8 kilograms of age should be given a higher dose. And what is the higher dose? The higher dose is 2 lakhs international unit oral. If the baby is not able to tolerate the oral dose, you can also give 1 lakh international unit IM. Okay, so please remember these two dosage. It is very important. Bigger bacha, badi dose is 2 lakh international unit oral. Okay, so I hope you've understood everything in this one. Now let's talk about the next series of questions in our test series number 2. So guys, are the questions clear? Any doubts here? Anything which you wish to ask? Done? Yes, Dr. Gandhi, yes, absolutely correct. Chalo guys, then let's start with the next set of questions. So we have a 34-year-old male came to you with headache since many months. The vision is a supervision, I would say, better than 6/6. This is supervision, but he has a lot of computer work to do. So he is cycloplegic, retinoscopic value is +3 diopter at 1 meter. He has problems for near vision blurring as well. So what is the diagnosis? So guys, please do not say it is presbyopia. No. The correct diagnosis here is a hypermetropia. Why? So if the retinoscopic value is +3 at 1 meter, what should be the refractive error? The refractive error should be +2 diopters here. Okay? The patient has a good near vision. The patient has a good distant vision, but the patient has a hypermetropia. That's why he is having a lot of headache here. He is able to manage everything, but he is not able to do the things correctly because he is having a hypermetropia. I hope this question is clear. Yes, everybody is saying yes. Dr. Abdullah, no beta, this is not presbyopia. I said this is why this is not presbyopia. First of all, the age is not matching. Dr. Abdullah, the age is not matching first of all. What is the second problem here? When you are doing retinoscopy, guys, you are getting a refractive error. And this refractive error is hypermetropia. Am I clear? Dr. Abdullah, it's a very straightforward question, but I'm just confusing you by giving so many things here. Hanji, Dr. Abdullah, can you show me a thumbs up if you've understood? Now, why computer vision syndrome? What is it? If the patient has a computer vision syndrome, this retinoscopic value would not be given. I would have given the retinoscopic value says no refractive error. Then you can think about a computer vision syndrome. Because of excessive computer work, excessive near work, the patient is developing a headache. Yes? Okay? Chalo. Now guys, we will be talking about refractive errors in this set of questions, and I have given you some important questions which can be there in your exam. So last year they have given you some question on solving the prescription power. They have given you questions on astigmatism. So we have kept similar things, but I have given you something additional. So I have given you one question on spherical equivalent. If you do not know the topic of spherical equivalent, let us solve it now. So first of all, what is spherical equivalent? See, understand the question. Many a times, guys, it happens that when I give prescription to a child which includes a sphere and a cylinder, many a times it happens that the child is not able to tolerate this cylindrical power. So he comes to me again with problem of adjusting with the glasses. So what do? I give him a composite number. A composite number which includes everything, eliminating the cylindrical value. So it is just a sphere. समझ आ रहा है? We call it equivalent. So what is it? Let us solve it. So what do? We keep the same power of the sphere and we take half of the cylindrical value. What is the half of cylindrical value? 0.5. Okay? And we add them algebraically. So minus 6 plus 0.5. We add them algebraically. So what does it become? It becomes minus 5.5 diopter sphere. Have you understood what are we doing, bache? I'm sorry. Hanji. So this has become minus 5.5 diopter sphere. We eliminate any cylinder from the prescription by giving the patient a new sphere. What is the new sphere? Keeping the same sphere, add algebraically half of the cylindrical value. So this gives patient almost equivalent vision as this prescription was giving. But now the patient is free from any cylindrical power. Understood, bache? So spherical equivalent can be another question for you. Okay? Please remember, this can be another important expected question this year. Spherical equivalent, right? Now, 3 years back, unfortunately, AIMS, INICT have given you some questions on Snellen's chart. So let us read some Snellen's chart related questions and understand the topic again quickly. So here I am asking you a very simple question. What is it? What will be the angle subtended by Snellen's optotype of first line when viewed from a distance of 60 meters? So a very similar question was there in your exam. I have just fiddled with the language of the question. So what we know already is the same thing. What do we know here? If this is the Snellen's chart, we know every letter makes an angle of 5 minutes of an arc from that respective distance. That means A makes an angle of 5 minutes of an arc at 60 meters. This makes an angle of 5 minutes of an arc at 36 meters. This makes an angle of 5 minutes of an arc at 18 meters, etc. So we know this by the knowledge itself. Okay. Now every letter is created in such a manner that the individual detail, all the individual details also make an angle of 1 minute of an arc at the nodal point of the eye. Okay. So please remember these two things. The correct answer to this question will be 5 minutes of an arc. Okay, friends, please remember. Right? Chalo. Now, important one. So, something from the refractive errors. What is the most common complication of pathological myopia? So, friends, first I would like to tell you what is the definition of pathological myopia. So, any refractive error which is more than minus 6 diopters and the axial length more than 26 millimeters with changes in retina. With retinal changes accounts to pathological myopia. So please remember first of all. Now pathological myopia or any other myopia behaves like this. They shut their eye, they make a pinhole apparatus kind of thing with shutting of their eye to make the things clear. So this is called as shut eye, classically seen in myopia. Now myopes have a larger eyeball. We know that we have a deep anterior chamber. They have a tendency of exophoria because they do not converge. Okay. Now they also have a high chance of POAG, pigmentary glaucoma and a nuclear type of cataract. Every word from this slide is important. The ray diagram is the image is formed just in front of the retina, right? That is myopia. Now please understand another very important slide. These are all the features of pathological myopia. Remember, they have a high chance of developing lattice degeneration, high chance of formation of rhegmatogenous RD, Foster Fuchs spots, lacquer crack, posterior staphyloma, a large cup to disc ratio. So all of them are seen in patients of pathological myopia. Okay, we have read that recently also. Now, so what do you think should be the most common complication? Anyone? Very good, Dr. Mohammed. Very nice. So this is macular degeneration. Please do not get confused by rhegmatogenous RD. Okay, please do not get confused. RRD can also be seen in pathological myopes. Rather, all of them can be seen in pathological myopes, but the most common thing is a degeneration at the level of macula. Okay, please remember. No, beta, this is not D. The correct answer is not D. That's what I am telling you. RRD can be seen in patients of pathological myopia, but when I ask about most common is not RD. Most common is degeneration at the level of macula. Okay, bache? Please remember. So this is called as breaks in the Bruch's membrane. Can you see these white things? These are breaks in the Bruch's membrane. Now what is this? We call this appearance to be tigroid appearance of retina. Tigroid मतलब like a skin of tiger. Tiger का skin कैसा होता है? Yellow, black, white spots है ना? So same thing here. We have black areas, yellow, white areas. We call this tigroid retina. Okay, important question. Tigroid retina. And can you teach how to calculate? बच्चे, we have some questions here. We'll discuss that. What is this picture? अभी इसके बारे में पढ़ा था ना? What was this picture? This picture is same as the lattice degeneration. Isn't it? Lattice degeneration. Okay? How do you treat lattice degeneration? By putting laser spots, laser barrage. So lattice degeneration, right? Chalo. A very simple wala question. So we have a 15-month-old baby, and this baby was brought to you with watering since 1 month of age. So the baby was very small, right? Baby had a history of watering since very early age. He was advised sac massage with antibiotics at the age of 3 to 5 months, but hardly any improvement was noticed by the mother. So what should be next management plan, guys? Very simple, straightforward question. Very simple. Hanji. Very simple wala question. Anyone? So here we will be doing syringing and probing under GA. Guys, I have given you a complete statement, but we can split the question, the options into 4, 5. So syringing can be separate, probing can be separate. So best is do a syringing and probing. Okay? Why wait and watch, Dr. Mansoori? No, bache. No, bache. So at the age of 15 months, do you think massage will help? No. The massage will only help till almost 9 to 11 months, right? Less than 1 year of age. If the baby is now grown up, you should do a syringing and probing. If I change the option to like 4 years, then for 4 years the correct answer would be DCR. For 4 years the correct answer should be DCR. Okay, bache, a simple question. Chalo. Now a really interesting one. So we have a 20-year-old girl who came for a routine checkup. You noticed an anisocoria. So first of all, what is anisocoria? Anisocoria is nothing but a difference in the size of pupil. Okay, so you notice that there is a difference in the size of pupil. And right side has an AD stonic pupil. So why I am shift this is to right eye? Because right eye AD stonic pupil is a slightly large pupil. What is AD stonic pupil? A unilateral large dilated pupil. Okay, bache. So I have given you the diagnosis here. The patient has a AD's pupil. Now you have to recollect everything about AD's pupil, because I believe that abnormal's pupil is an important question for your upcoming exam. या तो PG में या INI-CT में abnormal pupils में से तो एक question आएगा ही आएगा. Okay, you may get a question, right? Now, does this AD's pupil normally constrict to light and accommodation? Absolutely not. So it's a very sluggish reacting pupil. It reacts very slowly. So here again light reflex is lost, but accommodation reflex is present, and that too very slow, very sluggish. Very slow, very sluggish. Okay, bache? Now we have an AD's pupil. There is not a paradoxical dilatation. This is seen in cases of RAPD or Marcus Gunn pupil. Okay? constriction of both eye pupil with the with 2% pylo, that is seen in my eye, your eye, or normal eye. है ना? In normal individuals we have constriction of pupil with 2% pilocarpine. But what is here? This one. 0.125 pilocarpine is a very diluted solution of pilocarpine, and AD's tonic pupil is, the patient is hypersensitive to a cholinergic agent, isn't it? Dr. Veenu ने बिल्कुल ठीक बताया है. So the correct answer here is constriction of pupil by a very diluted solution of pilocarpine. Now what happens here, बच्चे? So there may be a problem in the ciliary ganglion, or there may be problem in the postganglionic parasympathetic pathway. So though these patients do not react to light, or they do not give a proper response on accommodation, but they became very hypertensive to pilocarpine or any other cholinergic agent. So the moment you put a pilocarpine drop here, a very diluted solution of pilocarpine, the pupil will quickly constrict. So that give you the diagnosis. Dr. Veenu, any other thing? और क्या देखने को मिलता है एडीज pupil में? और क्या मिलता है बच्चे? You get a vermiform iris constriction, and sometimes your deep tendon reflexes are also absent. ठीक है बच्चे, ये दोनों चीज़ें भी याद कर लीजिए. Deep tendon reflexes may be absent and you may have vermiform iris contraction. ठीक है. Now the next topic I consider is again very important, something from the chemical injury. ठीक है, something from the chemical injury. I expect this question may be there in your exams. ठीक है. So we have a 35-year-old male coming to you with a history of battery bursting on his face. My God, a chemical injury, right? 1 hour back. So that's a early case. On examination, this picture was shown. So what is correct about his condition? ठीक है. So is this a grade 1 injury? Let's discuss grading a little later. Proper eye bandage should be done. So guys, bandaging in chemical injury is not at all important. No matter how big is your epithelial defect, bandaging is not required. This patient has a very poor prognosis. I'm not saying a poor prognosis, but definitely the prognosis is not very good. Okay, why not very good? Because if you see here, the patient has a whitening here. We call it limbal ischemia. ठीक है बच्चे, you have a limbal ischemia. So I would say prognosis is not very good, but not very poor also. So steroids should be started. This is the first thing which I will do. Now guys, let's talk about chemical injuries in very brief. So chemical injuries of the eye could be causing the epithelial defect. Okay, so we have different types of gradings for chemical injuries. One is Roper Hall. At least remember the name, Roper Hall classification. We also have a Duas classification. ठीक है बच्चे. So Duas is very extensive. It gives you apart from prognosis the clock hour of limbal involvement and conjunctival involvement simultaneous. It's a very detailed classification. ठीक है ना. अभी मैंने जो अपना पेशेंट देखा उसमें क्या था, there was a limbal ischemia, but that limbal ischemia was less than 3 clock hours. So the prognosis is kind of good. Don't go much into details of the classification, don't worry. But just remember that if you have a limbal ischemia, if you see the patient limbal ischemia is there, the prognosis is not very good and also not very bad. ठीक है. Now steroids is the first drug which we have to give, right? Now what are the other drugs? Quickly let me enumerate. Steroids के अलावा cycloplegics to reduce the pain, to reduce the IOP anti-glaucoma drugs, vitamin C, tetracycline, sodium ascorbate, sodium citrate. Autologous serum can be given, and for prevention of dry eye, a lot of tear supplements should also be given. Okay, so this is a sum up list of everything you should give in injuries. Okay, very good, Dr. Patel. You are also absolutely right. ठीक है, चल. So we have a young female who complained of decrease in vision in both the eyes. Okay, on examination, the vision is definitely less. There was also a difficulty in reading the Ishihara chart. On retinal examination, the fundus is normal. So guys, is it a possibility? There is a decrease in vision, the vision is less, and there is a problem with the color vision also. So what do you think? There may be some problem with the optic nerve, yes or no? Yes, but you see the fundus is normal. So what are the options here? Let us see. Had this be optic glioma, first of all, optic glioma occurs in children. Okay, and there must be a history of proptosis as well. Yes, and the fundus would not reveal a normal one. Thyroid ophthalmopathy bhi nahi hoega, because you know, apart from that you will have other signs as well. Now what about papillitis? Guys, had this been papillitis, the fundus is not normal. Fundus would have shown disc edema. So the best correct answer here is retrobulbar neuritis. Why? The vision is gone. The pupils we have not mentioned. Color vision is gone, which is a function of optic nerve, and the fundus is normal. So patient has a problem behind the retina. Understood? Why the answer is retrobulbar neuritis, friends? I hope now if you go retrograde, you will be able to find out your diagnosis. If you go retrograde only, ठीक है बच्चे? चलो. So similar question which was there in your exam this year, sorry. So we have an old female coming to you for a checkup. She has systemic complaints, diabetes, hypertension. There's a long history of rheumatoid arthritis. So the moment I see the word long history of RA, what goes into my mind? Something related to sclera. Yeah, something maybe related to sclera or uvea, right? Now she is taking treatment for last 20 years. She has no pain and watering. There's no pain, there's no watering. And her vision is also normal. She actually has come to me for a routine checkup, right? But what I saw was this. So what is happening here, guys? The sclera is becoming thin. We are now talking about a patient who has a scleromalacia perforans. So for that, guys, I would like to tell you a brief about scleritis classification. It's a very, very important question. Most of you are correct here, bache, very, very good. So broadly, we can classify scleritis into an anterior and posterior scleritis. Anterior would be further classified into DNN. What is DNN? Diffuse nodular necrotizing. Now, necrotizing is further classified into divided into with inflammation and without inflammation. So, without inflammation, necrotizing anterior scleritis is what? This is your scleromalacia perforans. So, hota kya hai scleromalacia perforans? I'll tell you briefly. Basically, guys, it is a type 3 hypersensitivity reaction. There is no inflammation, so the patient will never have a pain. No pain, no watering, no redness, and rather I would say a very gradual decrease in vision. Patient may also be asymptomatic. Now you will say, madam, there is a necrosis and there is no inflammation. How is it happening? How is it happening? Isn't it? Doesn't this thing comes to your mind that if there is a necrotization, there should be inflammation? So what is the problem? Let us see. The problem actually is this statement. There is an obliteration of arterial supply and there is a sequestrum formation. Understood, bache? So because of that, though there is a necrosis, necrotizing kind of problem is there, but inflammation is not there. That's why there is no pain, absolute, almost the normal vision. You have a gradual thinning of the sclera, and this is very commonly, this is most commonly seen in patients, elderly females who have a long-standing history of rheumatoid arthritis. Okay, bache? So scleromalacia perforans is a very, very important topic. It has been there in your exams earlier, and again later on they can ask you. Chalo guys, so now talk something about neuro-ophthalmology, a very important expected question. So can anybody tell me what is the answer? Now, a patient has normal right gaze. That means the patient is looking normally on the right side. This is normal. This is normal. Okay. On attempting the left gaze, his left eye is abducting. His left eye is abducting and right eye fails to go towards the left. This is okay, but this is not happening. So what do you think is the lesion? Where is the lesion? So the lesion is nothing but at a right MLF. Yes or no? Everyone clear? So right eye is not going towards the left only. So where is the problem? The problem is in the right sided MLF. So guys, for discussion of this topic, I would like to tell you the horizontal gaze pathway. Okay, so everything is written here. I would like to tell you with the help of my eye, my face, my brain. So look at this very carefully. Okay, you understand today on your own face. Now, when I want to look on the right, okay, when I want to look on the right, that is right gaze. What is my governing body? What is my governing body? What is मोदी सर? मोदी जी कहाँ हैं जो राइट को लेके जाते हैं आपको? कहाँ है वो? लेफ्ट फ्रंटल आई फील्ड में बैठे हैं. ठीक है, लेफ्ट फ्रंटल आई फील्ड. प्लीज रिमेंबर, फॉर राइट गेज लेफ्ट फ्रंटल आई फील्ड. left frontal eye field will give command to the right side PPRF. Okay, right side PPRF gives command to two things. First, the right sixth nerve nucleus, which will go and innervate to the right sixth nerve, which will finally help my right LR to do this. Okay? Again, my right PPRF again through the MLF goes to the left sided third nerve. Left sided third nerve gives innervation to the left MR. So this eye moves here and this eye moves here. And that is very simplified way given in this diagram. So when the patient wants to look on this side, what will happen? The command from the opposite side frontal eye field come, right frontal eye field. It gives the innervation to the left sided PPRF. देख रहे हैं? Left PPRF gives two things. First to the left sixth nerve, the second through the MLF to the right sided third nerve. So what will happen? Third nerve MR moves, sixth nerve LR moves. Now you have understood? Dr. Shilpa, have you understood now, and everyone? So this is called as the horizontal gaze pathway. Please remember, right frontal eye field will be responsible for left gaze, left frontal eye field will be responsible for right gaze. This is a very, very important topic, right? Now, suppose there is a lesion, there is a defect of right side MLF. What will happen? Right MLF is innervating the third nerve and third nerve is innervating the MR. So MR movement will be hampered. What is given in this picture is this. Understood? Right gaze is normal, but right eye is not able to do adduction. So where is the problem? The problem is in the right MLF. We call it internuclear ophthalmoplegia. So I am talking about right eye. No. Everyone understood? So this is an important topic. You had a question on 1.5 syndrome. Yes or no? 1.5 syndrome long back. So similar to this, you can have questions on the rest of the things in horizontal gaze pathway. ठीक है बच्चे? Horizontal gaze pathway. मोहम्मद सहजान, आपको नहीं समझ में आए तो मैं आपको इधर लिख के बता देती हूँ एक बार और. ठीक है बेटा? Try to understand everyone. So when the patient wants to see on the left side, ठीक है? उल्टा चलते हैं हम, उल्टा चल रहे हैं. ठीक है बेटा? हम उल्टा चल रहे हैं. देखिए, this is the left side, the right side, MR and LR. ओके, मुझे लेफ्ट की तरफ देखना है तो मुझे कौन से मसल्स चाहिए बच्चे? मुझे लेफ्ट का LR चाहिए, मुझे राइट का MR चाहिए, यही चाहिए ना? तो इसको कौन इनोवेट करेगा? लेफ्ट को देखने के लिए माय राइट फ्रंटल आई फील्ड. ठीक है बच्चे? राइट फ्रंटल आई फील्ड ने क्या किया? लेफ्ट साइड PPRF को, ठीक है, लेफ्ट PPRF ने दो चीज़ें करी. क्या दो चीज़ें करी? द फर्स्ट वन, थ्रू द सिक्स्थ नर्व इट इनोवेटेड द LR. Also through the right MLF it innervates the third nerve and third nerve finally gives innervation to MR. समझ आया? Okay, so I am saying if there is a lesion of the right MLF only, what will happen? This movement will be hampered. If there is a big lesion affecting the right frontal eye field, the left gaze itself is gone. Okay, now clear everyone? ये समझ में आया? Now, very interesting question, something about staphyloma. So guys, ciliary staphyloma can be seen in all except. So I've given you very interesting options, very easy one rather. So the correct answer here is perforated corneal ulcer. So for that, I would first like to explain you what is a staphyloma. So what is a staphyloma बच्चे? Staphyloma is nothing but ectasia of the outer coat of the eye plus incarceration of the uveal tissue behind it. ठीक है, तो स्टेफाइलोमा गाइज आर ऑफ 5 टाइप्स मेनली. व्हाट आर द 5 टाइप्स ऑफ स्टेफाइलोमा? एंटीरियर, इंटरकैलरी, सीलियरी, इक्वेटोरियल और पोस्टीरियर. सो इन एंटीरियर स्टेफाइलोमा व्हाट इज हैपनिंग? द कॉर्निया विद द अंडरलाइंग आइरिस इज चिपकोफाइड एंड बोथ ऑफ देम आर मूविंग इन फ्रंट. समझ आया? आउटर कोट इज कॉर्निया, पीछे इज आइरिस, बोथ ऑफ देम फर्स्ट stick to each other and then both of them protrude. This is called as anterior staphyloma. So why does anterior staphyloma develop? It only develops in cases of Perforated corneal ulcer. Ciliary staphyloma is what? Let us have a look at these questions. So anterior staphyloma is protrusion of cornea plus iris. So we have cornea plus iris here, right? What about ciliary? Ciliary is in the ciliary body zone. You have protrusion of sclera plus the ciliary body behind. Intercalary कैसा होगा? Intercalary would be protrusion right there at the limbus. ठीक है? So again going back to the question, let's see. So ciliary staphyloma would be seen in cases of scleritis, glaucoma, trauma, but not in perforated corneal ulcer. In perforated corneal ulcer, rather we would be having a anterior staphyloma. Okay? So earlier they have given you question, anterior staphyloma is seen in. So it is seen in perforated corneal ulcer, and I have given you the opposite question. Okay? Please remember, important. Chalo. Now, I want you to answer this question. A patient gives you a history of tuna falling to the eye. All of the following would be a part of his immediate management except what? So, irrigation with the copious normal saline? Yes, immediately to yahi karna hai. Thorough slit lamp examination? Of course, it should be done. Removal of tuna by double eversion? Of course. See, tuna line is a very, very common type of alkali injury to the eye, right? Very common. Alkali injuries can be very damaging because any particle of lime or any particle of tuna which is there inside the eye can be a reason of a chronic inflammation and necrosis to the eye, okay? And it's going to damage your eye indefinitely. So penetrating keratoplasty can be done in chemical injuries, but it is a very late resort, very, very late. If nothing helps, you have a corneal opacity later on which is not being treated by any other modality, then penetrating keratoplasty can be done, but otherwise immediate management to definitely you should not do, okay? So this type of questions can be there. I told you chemical injuries are important, right? Now a very simple question, if you see this again, you should be able to diagnose. What are we talking about? First of all, what is this test? So this test is swinging flashlight test. What are we doing here, bache? In first go, the pupils appear to be normal. When I show a torch of light here, there is good constriction of both the pupils, good constriction. The moment I shift the torch to the other side, what do you see? There's a little dilatation from the previous one. So the pupil becomes now of this size. Okay? Again, you shift the torch back here. There's a good constriction of the pupil. So it shows a RAPD of the left side. The left side is the affected side, isn't it? The moment you put the torch of light here, there is a dilatation or no constriction of the pupil on both the sides. So this is tested by swinging flashlight test, and it is seen in cases of optic nerve pathology like optic neuritis. Okay, please see, this is not a normal pupillary reaction. This is not, of course, a Argyll-Robertson pupil. Okay, we have already discussed AD stonic pupil, so you may have picture questions, you may have a video related questions also from the same slide. Okay, chalo, now here comes a very, very important question. Anyone, what is the answer and what is this lesion? What do you call this? Ye kya hai? So friends, this is actually called as a junctional scotoma of Trachor. Junctional scotoma of Trachor. Now why does it happen? It happens when you have a lesion of the proximal part of the nerve. Here typically we have the problem on the left part of the proximal nerve. So I'm explaining you what happens. Let us see. So bache, I am sure that you remember it was there once upon a time in your exam. But they haven't given you this type of question. I have just twisted the question and given you the similar type of question in the form of a picture question. Okay, so let us see, guys, what happens. So you know that nasal fiber crosses to the opposite side, goes to the opposite optic tract. Now how is it happening? Let us see. Nasal fibers, before going to the opposite side, make a loop in the opposite optic nerve. Similarly, from this side, the infranasal fibers make a loop on this part of the optic nerve. So suppose there is a problem here. We call it left eye proximal part of the nerve. Proximal part of the optic nerve. Suppose the lesion is here. What will happen? The left visual field is totally gone. Yes or no? Left visual field is totally gone. And because these fibers, the blue ones, these fibers are the infranasal fibers of the right side. So guys, if infranasal fibers are damaged, the lesion should be, the defect should be supratemporal. So what do we call this? This is called as the junctional scotoma of trachea. Okay. Now let's go back to the question here. So we have a left eye anopia. We also see a supratemporal quadrantanopia on the right side. So left eye is totally gone. That means the problem is in left proximal nerve. Okay. I hope you have understood this topic as well, beta. So junctional scotoma of trachea and some atypical lesions of the visual pathway we have explained very nicely in the app. Kindly read topic of visual pathway and its defect also from the videos. Okay, please see them. Now here comes the famous question from the PARC 3-step test, and I would like to tell you something again with the help of my own eye, my fingers. Very, very, very simple. I give you a clue here so that you can solve any question from PARC 3-step test now. Okay? Now listen to me very carefully. So we have a patient who has a right hypertropia. Right hypertropia means what? Right eye is up. Okay, right eye is up. Okay, bache? Now this increases on right gaze. I have kept everything on right side so that you learn everything very easily. Okay, it increases on right gaze का क्या मतलब है? When the patient looks on the right side, this is normal, but the hypertropia is increasing. ठीक है ना? पहले ऐसे था, जब मैं ऐसे देखती हूँ तो hypertropia और बढ़ गया, increase हो गया hypertropia, right? Now what is it? The next one, and it increases. Ma'am, any other test discussion class before 4 December? Bache, tell me what do you want, Dr. Abdullah? We will do it, no problems. You're preparing for FMG exam. Dr. Mansoori, if you're preparing for your FMG exam, this wala question you can omit. Okay, PARC 3-step test question you can omit, bache. This is specifically for PG and INI-CET. Okay, this question please you can omit. Don't worry if you do not understand this question, you can omit that. Now it says that hypertropia increases on tilting on right shoulder. ठीक है बच्चे, मतलब क्या? When it increases on right shoulder.
Okay, I found this on the web for that hypertropia increases on tilting on right.
So hypertropia increases when I tilt my head on the right shoulder. Hypertropia increases. So I have drawn these things. Now with these 3 diagrams and the clue, how can we solve? Let me show you with the help of this diagram and my own eye. Everyone please see. So when we talk about the eye, we should know where are all the muscles. Okay, this is the clinical diagram. So again, medial rectus, lateral rectus. Please see, this is my superior rectus, my inferior rectus, inferior oblique and superior oblique. If you know that, then only you will be able to solve, otherwise everything will be wrong. Okay, again, medial rectus, lateral rectus, superior rectus, inferior oblique, superior oblique. Okay, next. The patient has a right hypertropia. Right hypertropia means what? We have to select 4 muscles from the 8 vertical muscles. Right eye is up means what? Either the depressors of right eye are not working, they are paralyzed, or the elevators of the other eye are paralyzed. ठीक है? Right eye ऊपर क्यों गई? या तो ये 2 काम नहीं कर रहे या फिर ये 2 काम नहीं कर रहे. ठीक है बच्चे? या तो ये 2 नहीं कर रहे या ये 2 नहीं कर रहे. Okay, so I have got 4 set of muscles from my first step, PARC 3-step test. ठीक है? Now second step says that find out those 2 muscles which increases hypertropia on the same side. मतलब क्या? देखो, so I have these 4 muscles from my face, these 4 muscles. Okay, now it says that hypertropia increases on right side. So I will omit out the muscle from which moves the eye to the left side. I'll only keep the 2 muscles which take my eye on the right side. तो मैंने क्या किया? मैंने इन 4 में से, I have 4 muscles, मैंने इन चारों में से वो muscles को उड़ा दिया जो muscles आँख को left लेके जाती हैं. And I have kept only 2 muscles which take my eye on the right side. So I have now these 2 muscles. Look at my face and look at the diagram. I have taken right sided this one and left sided this one, because these are the ones which are on the right side. Okay bache, everyone now see. So I've got two set of muscles from my step number 2. Now step number 3. In step number 3 bache, understand what is called as a corrective phenomenon. So everyone please see, when I move my head like this, if God has not given us corrective mechanisms, my whole world would be twisted upside down. Yes or no? But God has given us some corrected mechanisms by which my world remains the same. Stay near with me. So what is that mechanism? Please see. When I tilt my head to this shoulder, my right eye undergoes intorsion, my left eye undergoes extorsion. This is the protective corrective phenomenon. So what is it? When my right eye goes like this, my right eye undergoes intorsion, my left eye undergoes extorsion. Okay? Now, if my right eye is undergo intorsion, which muscle do I want? Sin. Sin. Superiors are intorters. Okay? Yes? Rad. है ना? Sin is this. So superiors are intorters. That means inferiors are extorters. Yes or no? We know why the mnemonic. If superiors are intorters, the inferiors are extorters. We know this already now. So if my patient is developing an increase in hypertropia, when I move my head like this, I would need a superior muscle which will bring my eye into intorsion. So do I have a superior muscle here? Absolutely not. I have an inferior rectus here. So this muscle is not the above muscle which is causing the problem. Now, I want a inferior muscle here which brings my eye into extorsion when I take my head here. So I have the muscle here which is definitely an inferior muscle, and this is inferior oblique. So this is my answer, left sided inferior oblique. Okay, now you read this again and then you have problem, tell me. I'll again explain you very briefly. Look at me. Right hypertropia means right eye is up. Right eye is up means I have these two muscles. Either of these two muscles are paralyzed or either of these two muscles are paralyzed. Now, hypertropia increases when I look on the right side. So I'll eliminate the muscles which take my eye on the left. I'll only keep the muscles which take my eye on the right side. So I'm shortlisted with two muscles. Okay? Now when I move my head here, my right eye undergoes intorsion. In. So I want a sin, superior, but I have an inferior here, so I'll take it out. My left eye has to undergo extorsion. So for extorsion, I want an inferior. Inferior is here, inferior oblique. So I have this muscle with me. The answer is left inferior oblique. I hope this is clear to everyone. So guys, any question, any language, any right or left, you can answer if you solve this question nicely. Okay, bache, read this again. Now again, I think that this question can be there in your exam from ptosis. So what is Marcus-Gunn phenomenon? Important expected question. Marcus-Gunn phenomenon is nothing but this. See what is happening. So right eye, there is a ptosis. And when the baby moves the jaw to the opposite side, what is happening? So this phenomenon is called as Marcus-Gunn jaw thinking phenomenon. What is happening? Please see. LPS is normally supplied by which nerve? LPS is supplied by the third nerve. But what is happening here? The third nerve is gone. There is a problem with the third nerve. Now instead of third nerve, LPS is supplied by a branch of fifth nerve. And fifth nerve also supplies your pterygoid. So whenever the pterygoid moves, टेरिगॉइड मूव कैसे करता है? जब ये ऑपोजिट मूव करता है ना, या फिर खाना खाते हैं, च्यू करे या ऐसे मूव करे तो क्या होएगा? दिस अ को कॉन्ट्रैक्शन ऑफ द टेरिगॉइड एंड द एलपीएस. सो improvement of ptosis. So this is called as Marcus-Gunn jaw phenomenon. So there is the aberrant correction regeneration in third and the fifth nerve. Very good, Dr. Mohammed Saj. Very good. Okay, bache, it can be a picture question for you and it can be a question like I have given to you. Aberrant regeneration in third and fifth nerve. Right? हाँ जी, पार्ट 3 स्टेप टेस्ट समझ में आ गया है सबको? Show me a thumbs up if you have understood, बच्चे. Part 3 step test. The question, is it clear to everyone? Now let's move on to something simpler. This is a picture question, a ray diagram. If you see carefully, we have 2 point of foci. It's not a single point of foci. So this is not hypertropia. Guys, we are talking about astigmatism and we are talking about the compound hypermetropic astigmatism. Okay, bache? We have a compound hypermetropic. So astigmatism can be divided into 5 types depending upon the ray diagram. We call it simple myopic, where one is focused on retina, one in front. Simple hypermetropic, where one at retina, one behind retina. Compound myopic, where both in front of retina. Mixed, ek aage ek piche. Compound hypermetropic, both are behind retina. So this is a very very important question. This is nothing but a compound hypermetropic astigmatism. Okay friends, chalo. Now again an expected question in your exams. This chart is nothing but a Bailey and Lovey chart. Please don't get confused. This chart is not Snellen's chart. Snellen's chart has one letter in first line, two in second, three in third, and so on. Bailey and Lovey chart is very very important for your research purposes. Why research purposes? Because every letter in a line has been given a particular log-mar value. Okay, so every letter has been given a particular log-mar value. So when you want to do some kind of research or some kind of publication, so you want vision to be very very specific. So researches के लिए हमारे पास है Bailey and Lovey chart. We also call this chart to be log-mar chart. ठीक है, log-mar chart. Another name of this chart is ETDRS chart. Alright, so please remember all of them are important. Chalo. So something from papilledema, friends, a very very important topic again. Papilledema is nothing but edema of the disc where vision remains normal, pupil remains normal, functionally the optic nerve is normal, but you see a swollen disc. Okay, so if papilledema is there, disc is enlarged. Will you have a normal blind spot? No, this is the only condition where you have a enlarged blind spot. Now, when we talk about acute papilledema, vision is normal, but in chronic stages, vision is gone. What about normal color vision? So again guys, in chronic stage, patient will not have a normal color vision. The functions of the optic nerve can be deranged when the patient moves into the chronic one. Okay? What about this? This I have told you. In early stage or in acute papilledema, the vision is normal, the pupils are also normal. Okay, bache? So this appearance is also called as an angry sun appearance. Yes or no? This appearance is also called as an angry sun appearance, right? You see disc is edematous, the cup is not here, the veins have become dilated, tortuous. You may also have pattern folds. So see, these are some features of papilledema. What you also see is an enlarged blind spot. Very famous question, picture question can also be there from that. Okay? Now, we have another question here where I have asked you later on champagne cork appearance. Let us see what is champagne cork appearance. So guys, in chronic established papilledema, you may have three type of things. Chronic में disc को क्या होता है? Disc is enlarged, but now it is not hyperemic. It becomes as if we are talking about a champagne cork. Okay, so this appearance is called as a champagne cork appearance. Now obviously, because this is a chronic stage of papilledema, what do you expect will happen to the vision? Vision will be gone, pupils are abnormal, and the color vision is gone. So the functions of the optic nerve are gone, right? Optociliary shunts, can you see some abnormal torsional vessels on the disc? So you can also have optociliary shunts as well. Okay, what is the third thing which I am telling you? This is called as corpora amylesia. This is nothing but accumulation of calcium over the disc. This is also seen in chronic stages. Okay, so important. Chalo. So guys, again, if you're preparing for your FMG exam, this picture question is not important. I saw some students are there from FMG exam. You can skip this question, right? So we have a young patient who comes to you for cosmetic squint surgery. What is your diagnosis after examination? So pattern squints are something which can be rare in exam, INICT and NEET PG. तो देखिए क्या है बच्चे, whenever some type of question is given to you, gazes are given. See the primary gaze first, the central wala primary gaze once. ठीक है? Now I am sure that you are able to see that there is an exotropia. The eye is going out. Can you see that? Yes. Now, what is happening when the patient is looking up? कैन यू सी देयर इज अ मार्क्ड इंक्रीज इन हाइपरट्रोपिया. यहाँ पे है, थोड़ा बाहर है, जैसे ही ऊपर देखते हैं बाहर बहुत ज़्यादा हो गया, इजंट इट? सो अब जब नीचे देख रहा है तो क्या हो रहा है बच्चे? कैन यू सी व्हेन द पेशेंट इज लुकिंग डाउन द एक्सोट्रोपिया इज लेसनिंग, इट इज डिक्रीजिंग. सो इजंट इट मेकिंग अ काइंड ऑफ वी? Appreciate it, isn't it making a kind of V pattern? So this pattern is called as a V pattern exotropia. Now what is a pattern squint? Let me tell you. Pattern squint is a type of variation in squint where these squints are horizontally comitant but vertically they are incomitant. मतलब जैसे ही पेशेंट ऊपर देखता है तो स्क्विंट का साइज बढ़ जाता है, नीचे देखता है कम हो जाता है, और वाइस वर्सा. Okay, so we can have different pattern squints. We can have A pattern squint, we can have V pattern squint, X or Y pattern squints, right? Now I'll tell you what is A esotropia. ठीक है, try to understand what is A pattern esotropia. What is A pattern? A मतलब ईजो है पर A बना रहा है, मतलब क्या कि प्राइमरी गेज में there is a little esotropia. Please see everyone, there is a little esotropia. Patient looks up, ESO becomes like this. When the patient looks down, the ESO becomes almost normal. So isn't this making a A? Yes or no? So we call it A pattern esotropia. Okay, patient looks up, the esotropia increases. Patient looks down, the esotropia decreases. Okay, this is called as A esotropia, and this is typically a patient of a V pattern esotropia. All right, so pattern squints FMG students can leave. This is not important for you, but this is important for everyone. So what is the famous Worth-Ford dot test? Let me first show you and tell you what is Worth-Ford dot test, and then I want you to answer the question. ठीक है बेटा, देखिए सभी लोग. So Worth-Ford dot test is nothing but a test to refine your I'm sorry. Worth-Ford dot test is to check the binocularities, to check the binocular vision. ठीक है. Now we ask the patient to wear the red-green goggles, red in front of the right eye always and green in front of the left eye always. ठीक है बच्चे. Now what is the use? Right eye से उसको सिर्फ red दिखेगा, left eye से उसको सिर्फ green दिखेगा. Okay. So red glass filters all the rays except the red color. The left eye, the green color filters all the colors except the green color, right? So what will happen? If I have a normal binocular vision, when I see these 4 dots, I'll say I'll see 1 red, I'll see 2 green, and I see a mixture of white and red. ठीक है, the white वाला would appear to me as a mixture of white and red. Now you try to interpret what will happen. Everyone. So red grass should be put in front of right eye always. ठीक है, it does not have 2 red, it has rather 1 red, है ना? ठीक है. Now if the patient has a right eye suppression, right eye suppression का मतलब क्या? Right eye suppression का मतलब ये that if the patient is not able to see anything from the right eye, what will he see? He will see 2 green as 2 green and 1 white is also appear to be green. So patient will say, I can see 3 green dots. That is the correct statement. अगर उसको right eye से नहीं दिख रहा है, right eye से नहीं दिख रहा है, so he will see 3 green dots. But if the patient see 5 dots, that means the patient has a diplopia. So can anybody tell me what will be the patient interpretation, inference when the patient has a left eye suppression? हाँ जी, कौन बताएगा? If the patient has a left eye suppression, what will be seen by the patient? Dr. Prithvi, A and V. No बेटा, it is for exotropia as well. अभी जो मैंने एक क्वेश्चन दिया है वो exotropia का ही तो है. Dr. Prithvi, the question which I have given you in the exam here is for the V pattern exotropia. The example I have stated you is for A esotropia. Okay beta, Dr. Prithvi. Anyone? If the patient has a left eye suppression, what will he see? What will he say? He will say that I can see 2 reds. Isn't it? He won't be able to see anything from the left eye, so 2 greens are gone. 1 red, the top one, below one will also be seen as 2 red. Yes, very good. ठीक है, so I consider that you have understood this. Okay, चलो. Now a very simple question, very simple. You should be able to answer this. So patient presented with unilateral proptosis and a bilateral abducens palsy. So bilateral abducens palsy is what? Nothing but a cavernous sinus thrombosis, है ना? Why? Because you know that cavernous sinus is very close to your orbital apex. So if you have problem in the orbit, there's a orbital cellulitis, the infection can go to the cavernous sinus. And if you know the cavernous sinus anatomy well, you know the abducens nerve is in the substance of the sinus. So if there is infection of the cavernous sinus, the abducens nerve is the first nerve to get involved. If it is the first nerve to get involved, you may have a loss of abduction. Now why I have said bilateral? Why bilateral? Because if you know the cavernous anatomy, cavernous sinus anatomy well, you should be knowing that there is an intersinus spread. So if infection is in one sinus, it can go to the other sinus also. So you will have a bilateral proptosis, right? Patient may have a bilateral proptosis. Please see, it started with unilateral and it has gone to bilateral side. Okay? Very good, a very simple question, but a very important one. Now, let's see something from the paralytic squints. So a patient comes to you with diplopia at sudden onset. This is a very typical complaint of paralytic squint. Yes, he has a history of diabetes and hypertension. On ocular examination, the vision is almost normal. The cataract is early. I'm not bothered about it. Retina is also normal. But when you saw the pupil, pupil is non-reacting. Pupil में direct or indirect light reflex नहीं है. So what is the correct answer, guys? What is the correct answer? A simple one, a easy one. The correct answer here is definitely a third nerve palsy. Okay, so a third nerve palsy patients, like here the patient has diabetes and hypertension, may be a medical cause of third nerve palsy. And what is the characteristic thing here? Please see everyone. There is a ptosis because LPS is gone. The eye is looking down because superior oblique is the only muscle which is intact, which is also a depressor. The eye is also out. Why out? Because lateral rectus is intact. Okay, I am sure you know LR6SO4. So both the muscles are intact, both the nerve supplies are intact. So eyes are down and out. ठीक है बच्चे? If you show a torch of light here, pupil will not be reacting here, right? Third nerve palsy is an important topic. Now, champagne cork appearance we have also already discussed. It is seen in cases of chronic papilledema. Important expected question. Okay, this is nothing but a champagne cork appearance seen in chronic papilledema. Now, cortical blindness. Hanji friends, what is important about this cortical blindness? I hope you know when the patient has a lesion in the visual cortex, I hope you know that the pupil behaves normally. So pupillary pathway fibers are not going to the visual cortex. If you remember your pupillary pathway, you must be knowing that the pupillary fibers are not going to the visual cortex. So if you have a defect in your visual cortex, no matter how poor your vision is, if you have become blind because of your cortical problem, the pupils will always behave normally. I hope you understand that. So you will have a normal direct reflex and you will also have a normal consensual light reflex. Have you understood, bache? Dr. Mohammed? Visual cortex problem. Pupils behave normally. Why? Pupil behaves normally because the pupillary pathway fibers are not relaying into the visual cortex. They are having a different pathway. They go off from the pretectal nucleus to the Edinger-Westphal nucleus. Then they move on to the third nerve, the ciliary ganglion. So it's not going to the visual cortex, right? Please understand important topic. Now, RBSK from your PSM Rashtriya Bal Suraksha Karyakram is an important topic. Please remember, we have 30 health conditions. Government of India pledges to take care of the children from birth till 18 years of age, and 4 ocular disorders are also there. I would say most of the disorders are there, which includes vitamin A deficiency, congenital cataract, ROP, and any cause of visual impairment. So what is out here? Congenital glaucoma is not included. ठीक है बच्चे, please no, it's not vitamin D. It's not vitamin D. The answer is congenital glaucoma. I said what is not included. Okay, which is not included. So congenital cataract is included, ROP is included. ROP is a very important one. Vitamin A deficiency is included, but congenital glaucoma is not included in RBSK. ठीक है बेटा, important question. चलो. So a 30-year-old man complains of difficulty in reading the newspapers with his right eye 3 weeks after sustaining a gunshot injury. The most likely diagnosis is, it's a clear cut question. What are we talking about? We are talking about sympathetic ophthalmia. Why? The patient is having a penetrating injury, isn't it? There is a history of penetrating injury. Penetrating injury, which happens mostly to the ciliary body, are likely to get converted into sympathetic ophthalmia. The trauma is here in this eye, but there is a bilateral granulomatous panuveitis. Bilateral granulomatous panuveitis. Now, what is the first symptom of sympathetic ophthalmia? First symptom is this: difficulty in reading, presbyopia नहीं बोलते इसको, difficulty in reading the near things. Okay. So how do you treat it? You should give a lot of steroids. Steroids are the treatment. How will you prevent it? For prevention, you could have done a enucleation. Please remember, enucleation is not a treatment. Enucleation is only a prophylaxis. It's a prophylaxis. ठीक है बच्चे? Please remember. Now, a simple question for INICT and PG entrance exam, not for FMG. ठीक है? Please see what is this. A patient is having a prescription of glass as -1 at 90 degrees, -1 at 90. And now they are asking you which type of astigmatism is this. Is this simple myopic, hypermetropic, or what? So with the help of prescription, would you be able to tell what is it? So guys, what I do is I'll give you a trick. मैं एक ट्रिक दे रही हूँ जिससे आपके सारे MCQ सॉल्व हो जाएंगे. The only thing what you have to remember is this: a plus at 90 degree is with the rule. A plus at 90 degree is with the rule. ठीक है? So if plus at 90 degree is with the rule, a minus at 90 would be against the rule. If plus at 90 is with the rule, a minus at 180 is also with the rule. Yes or no? So just remember one thing. Okay. Now looking at this prescription, what do you think this should be? This is a simple myopic astigmatism, and this is against the rule because it's minus at 90. Yes or no, friends? It is a simple myopic astigmatism. What would be the prescription for compound myopic? Compound myopic would be something like this. Please see everyone. Compound myopic would be something like this: -1 diopter sphere, -1 diopter cylinder at 90. So you have two types of minus here. Okay, this will be your compound myopic astigmatism. Okay. Let me give you an example of a simple hypermetropic astigmatism. Okay, I'm giving you an example of simple hypermetropic now. Simple hypermetropic would be something like this. This. Only 1 plus. Okay, what would be compound hypermetropic? 2 plus. Cylinder and sphere. Both will be plus. Okay, friends? I hope now you have understood. I hope you have understood now how to tell what type of prescription is this with the help of the written one. Okay, so again, what do you have to remember? Plus at 90 is with the rule. If a plus at 90 is with the rule, everything will fall into place itself accordingly. Okay, please read this again. It's important for PG entrance and INICT. Important. Chalo, a very simple common sense wala question. Eye is deviated out and down. The question ends here, I would say. If the eye is out, if the eye is down, what is the likely nerve injury here? The likely nerve injury here is the third nerve injury, oculomotor nerve. Okay? So in the videos also I have told you many times that a down and out eye, please remember it is a third nerve, the oculomotor nerve injury. Right, friends? A down and out eye, very classical. Now we have the last question here, which is an interesting one, something from the visual fields. Now, we have a 64-year-old hypertensive patient complains of difficulty in reading. He states, the things are blurry, I sometimes lose my place. It's a very, very important statement. See what is he telling. What happened, Dr. Shilpa? Batao beta. I still see things after I've looked away, as shown in the picture. Now, when you examine, everything appears to be normal. Vision is normal, pupils are normal, fundus is normal. And what is the visual field effect? Let us see. The visual field effect is something like this. So, what is it? It is nothing but a left-sided homonymous hemianopia. Your left field is gone. So, you have a left homonymous hemianopia. It's a left homonymous hemianopia. Now, guys, So if you have a picture here, you are able to tell the problem is left homonymous hemianopia. But what if the picture is not given to you? Suppose the picture is not given to you, then would you be able to solve this with the help of a picture? Would you be able to tell? Now I am telling you this. Please listen to me very carefully. Except Arabic and Urdu, most of the languages are read from left to right. Yes, we read from left to right. So what is the complaint of the patient? Listen to this carefully. She says that I am able to read everything, but when I come back, I lose my place. I don't know where to start from because she is having a problem on the left side. The left side is gone. So she is not able to know where to start again. But when she reads, everything is okay. So the problem is on the left side. That's why we call it a left homonymous hemianopia. Guys, have you understood the problem? Understood the problem, बच्चे? It's a very very important question. Okay, V exo मैं फिर से बताती हूँ बेटा. देखो इसको, बहुत ही simple है बच्चे. पृथ्वी देखो इधर. So can you see in the primary gaze there is a exo. This is a exo. Can you see this is a primary gaze, is a exo. When the patient looks up, what is happening to the exo? Exo is increasing. When the patient looks down, the exo is decreasing. So isn't it making a V pattern? पृथ्वी V बन रहा है ना ये, तो V बन रहा है इसलिए इसको V pattern बोल दिया. Okay, now see this question again, you will understand yourself. Now see, forget about the rest of the gazes, just look at these three. Can you see a V here? There is a exotropia which has increased a lot when the patient looks up. Okay, and here the exotropia is little decreasing. डॉक्टर शिल्पा स्पेक्टिकल पावर बताऊं? ठीक है, मैं बता रही हूँ स्पेक्टिकल पावर. आई गिविंग यू क्वेश्चंस. ठीक है, पृथ्वी शो मी अ थम्स अप बेटा इफ यू हैव अंडरस्टूड. नहीं समझ आया? डॉक्टर शिल्पा एंड फॉर एवरीबॉडी लेट अस सॉल्व फ्यू क्वेश्चंस. So this is the power cross. Okay, this is the power cross. Power cross मतलब कि जो रेटिनोस्कोपिक वैल्यू आया है, ठीक है, this is not the spectacle power, this is the retinoscopic value which I have got after neutralizing the reflex. So I am doing my retinoscopy, this movement is neutralized by +3 here, this reflex is also neutralized by +3. ठीक है, नहीं मैम का ही प्लीज़ मैम के ही बता दो. हाँ जी. So this is done at 1 meter and this is done under atropine. Okay, Dr. Shilpa. So when we are making a power cross, these are the retinoscopic findings. How to find out the spectacle prescription? Let us read. So whenever we do that, we make a correction. What is the correction here? From +3, -1 would be corrected for atropine, -1 is corrected for the distance. ठीक है, again here. So this becomes +1 and this becomes +1 after the correction. So what should be the spectacle prescription? Spectacle prescription should be +1 diopter sphere. समझ आया? We have to make 2 corrections, one for the distance and one for the cycloplegic agent. Dr. Shilpa, for you another question. I am giving you another question. If the power cross or the retinoscopic finding is this, it is done at 1 meter. What is the spectacle number? Cycloplegia is not given. Cycloplegia is not given. What is the prescription beta? What is the spectacle power? Spectacle power is 0, no requirement, because we will be doing a correction. So it will become 0. Okay? So if I have done this under atropine, then atropine is for this -1 diopter sphere. Shilpa, these are the corrections which we make beta. Always we make some corrections. For distance, one is subtracted for 1 meter. For atropine, cycloplegic, we must make a correction of 1. ये करना होता है बच्चे. डॉक्टर शिल्पा, यू हैव द ऐप ना बच्चे, एक बार रेटिनोस्कोपी को पढ़ो इसको. रीड रेटिनोस्कोपी फ्रॉम स्टार्टिंग. नो, नॉट 0.5. Not 0.5 we take for hometropine. For hometropine, if hometropine is used as a cycloplegic, correction of 0.5 is made. Okay, for atropine, the correction of 1 is made, always. Shall I give you one more? Okay, if this is the value, -1, done at 1 meter, it is done at 1 meter and it is done under atropine. Now, what is the spectacle power, बच्चे बताओ? What is the spectacle power now? Now it should be minus 1, minus 1, minus 1, minus 1, minus 1, minus 1, which becomes minus 3 diopter sphere. Okay? Not plus 1, minus 3. Algebraically sum करना होता है, right? Alright guys, so I think it was useful for you. You've understood and the test was solved. Whenever you have time, just go through these questions one or in a 2x speed so that you learn all the concepts again. And I will definitely tell you that QRP videos are uploaded, guys. So you can go through the QRP videos and read the topic well. I have discussed in my QRP session most of the things in a very brief manner. So you can go through the QRP sessions. The new sessions has been uploaded at DocTutorials app. So that will be very, very helpful for FMG students and PG students. You must do the QRP before you go your exam first. Okay. So I hope the session was useful and fruitful for you. And if you have any other suggestions, please let me know. This is my YouTube channel also, and you can tag me at the DocTutorials site anywhere at Instagram or Telegram. We can be in touch, we can be in contact. So whatever trouble comes to you in your ophthalmology preparation, please ping me, you can tag me, you can ask me anything in ophthalmology. Okay friends, so best of luck. That's all from my side, and best of luck to everybody for your upcoming exam. I'm sure that you will do well, you will do great. Okay, so any suggestions you can just type down in the chat section here for further videos, for further content, whatever you want us to teach you, whatever classes you want we should take for you, you please let us know. Okay, so thank you very much. It's been lovely to be here and talking to you guys. Best of luck, have a great day.